Good evening, members, and welcome to this evening's Health and Adult Social Care Overview and Scrutiny Committee. Do I have apologies for absence, please? Councillor Wilding?
Councillor Barrett's running late.
Thank you, Councillor Wilding. Councillor Field?
I'm substituting for Councillor Prenter, Mark Prenter.
Okay. And Councillor Field, we might get you a microphone over there, because I know you haven't got a microphone in front of you, so we'll work one out for you there. Councillor Howcroft-Scott?
I'm subbing for Councillor Douglas Hamadishay.
Thank you very much. Members, can I sign the record of the meeting held on the 14th of October 2025 as correct? Agreed. Thank you very much. Urgent matters. I do have one urgent matter just to update members on. You remember in the last meeting we had the item on the pharmacy and we were going to write a joint letter. The HAS committee, Public Health, David was leading that, and the ICB were going to countersign. At this time, the ICB are not countersigning the letter. The letter we've done is pretty clear. It's not blaming any side, but asking the government of a request to do something for the future for the PCN, etc. I know that our Director of Public Health likes the letter and has agreed and has added bits himself, but maybe for the ICB colleagues this evening, for them to review, because we will bring that letter back to the HAS meeting next week, and it will be mentioned whether it's just going to be from HASC and Public Health and without the ICB being involved, which will be extremely disappointing. So that's where we are at the moment on that update. Are there any disclosure or pecuniary interests or other significant interests or evidence of whipping this evening, members? Nothing at all. Thank you very much. Can I always just remind everyone, those that are coming up to speak, to keep introductions to a bare minimum. Members have read the papers. I can assure you they've read the papers. So just update on anything new, and then we will ask questions, and it gives us more time to focus on the key points. Can I ask Adam Doyle to come up, please? It's a bit of a long walk there, Adam, but we'll get you walking up. And it's item 5, NHS Kent and Medway update. Welcome, Adam. I know it's you're going to have your colleagues join you as well. Obviously, we're taking the report as read, Adam, but I know many members have not met you and don't know you, so it'd be welcome to do an introduction and a bit of a highlight of the paper. Over to you, Adam.
Sure, and thank you and good evening, colleagues. Thank you for inviting me here today. So I'm Adam Doyle, I'm the new Chief Executive of the ICB in Kent and Medway. I'll take the report as read, really, but there's probably a few highlights just to really sort of amplify, and then we can get into any conversations you'd like to have. So this is now my 5th week in Kent and Medway, and I've been very well welcomed by many parts of the health and care system, and I want to thank and extend my thanks to the council for all of their sort of discussions, give me feedback about what needs to change and improve in the health system here in Medway. My report kind of does two things. It kind of frames the national context in which the NHS here in Kent and Medway needs to respond. So you'll have seen the 10-year plan that was released over the summer, and the requirement now, looking across the whole NHS, for us to look at how we deliver the 3 shifts that are outlined in that plan, which therefore aims to promote a more neighbourhood-based model of healthcare, working with a broad partnership of the voluntary sector, our primary care organisations, our broader NHS Trust, but also our non-statutory partners. It's a really important inflection point for the NHS in general, but also that comes at a time of significant challenge to the NHS both nationally, but also there are challenges here in Kent and Medway as well. And looking at the local and strategic diagnosis of the system, I've been asked to give a report back nationally about my findings. That will be coming to conclusion in December, and at which point then I'll aim to share that with the committee about what I found. But I would have thought you'd have asked my initial thoughts, having been in the system for the last 5 weeks. First of all, you can see hard work of many NHS workers every single day across the system. And I see that both in primary care. I know we have work to do in this part of our health economy, particularly in numbers of GPs, in numbers of dentists. There are significant issues that people are experiencing every single day. But also there are some other challenges that sit globally for the wider Kent and Medway system. When we talk about the NHS resources, there is a significant underlying deficit to the system, and I've asked for some work to be commissioned to understand that in detail. That should aim to report to me mid-January on current timelines, which will actually give a size of the underlying financial issues that the health system here faces. In that context also, across the whole of Kent and Medway, there's 225,000 patients waiting over 18 weeks, which is one of the largest sizes of waiting lists in the NHS in the country. And also we've seen some significant areas that we need to focus on. What my approach will be is to work openly with you and all of the NHS partners. So the ICB has just under a £5 billion commissioning budget and therefore has a responsibility to allocate the resources across the health and care system to get the best value and to get the best return going forward. I am a clinician, I'm a physiotherapist, I've only ever worked as a clinician in deprived communities. I understand the uniqueness of the Medway health and care system and what the population require, and I'm looking forward to meeting people. And I have a number of visits lined up over the coming weeks to meet a number of the people at the front line to get a better understanding of what the population need. But really, the brass tacks of this are that as part of what the system requires, it requires quite a robust improvement plan. To therefore attend to many of the issues that I've outlined. And in my report, it covers off the 6 main areas we'll focus on, which will be acute services transformation. So what are the right things in our hospitals and how do we therefore ensure they meet the best in class for what our population need? I need a really strong neighbourhood model. There are some great things that are happening in different parts of the system, but it now needs to move at a greater pace. And I'm working very closely. I know you'll come to that as part of the community services procurement, but it's important that that now starts to bear fruit in achieving neighbourhood health. The ICB is going through significant changes. You'll be aware of the 50% headcount reduction to therefore manage that. We've launched a voluntary redundancy scheme, but it's also important that we describe the strategic commissioning approach that the organisation needs to go through. ICBs across the country now need to be stronger about how they therefore deliver commissioning, and I'm working very closely with the leadership team to get that right. I've mentioned the financial recovery. So as a clinician, I find the best way to approach financial recovery is to work with our clinical teams to shape that and get that right. And we're really keen to make sure we've got robust clinical leadership to get that right. And we point to our culture. And the last bit is, with the revolution that requires us to look at how we do things differently, there is the absolute requirement to therefore take a real different approach to digital and data technologies across the system. In terms of how we want to work, so we want to work with you both as an overview and scrutiny committee, but also generally in terms of how we therefore co-design this together. I'm aware of, I've had really great discussions with members of this committee about how they found working with the ICB. I aim to sort of foster a really open and transparent culture, hence why I'm here tonight, and I'll stay all night to hear what my colleagues across the NHS have to say and your questions and feedback to that. I want to do a reset, if that's possible with you, about how we work together to get the right thing. I believe in robust scrutiny, so really open to any question and challenge that you might ask. In terms of the things I've also got to approach, you will imagine that 5 weeks in, I've looked at decisions that have been taken by the organisation. Some I would agree with, some have got hindsight that I think may be different, but I'm working really closely to understand that. The first one, I suppose, that you'll want to cover at some point will be the community services procurement. So whilst I know there's been many discussions that have been had with the committee about the history of that, there's also work we're now doing about anything else that's in the community services space that wasn't part of that original tender. And the day before I joined the ICB, there was a decision taken by the board to therefore work through what the model would be for those other services. We want to do that with you and do that really openly and transparently, and the team will happily go through the steps we're taking to work that through with you. So in summary, quite a lot to do. And, you know, I'm not coming in saying that I have all the answers, but I'm coming in to say what is the structure to therefore get that right. My approach has been it tends to be done best by working with people to therefore respond to that. And that requires all of the NHS leadership teams to work together to achieve the best and common goal, but also to be really clear where things aren't working and what we do to get that right. as part of the organisation, I read every complaint, I read every correspondence that goes out from the community. All those things are important to me. So you are also residents within the system who I'm responsible for, but also in terms of what your constituents are telling you, it's a really important piece to get right. In terms of how we have dialogue together, I'm just working with our team to therefore make sure we've got the right route in where if you want to raise concerns or give feedback, how do you best do that so we can do that quickly and on a timely basis. So that's kind of my opening piece. Lots I'm sure we'll work on, but I hope that's a helpful summary, and back to you, Chair.
Thank you very much, Adam. Members, Councillor Wilding.
Thank you. First, welcome to Medway. It's the best place you've ever worked. I'm glad you mentioned GPs in your opening, because as members know, we rarely talk about GPs in this committee. Sorry, I shouldn't make jokes. I saw in the Health and Wellbeing Board, which had a document on this earlier this week or last week, we are still 10% less GPs than in 2017. And obviously the population's risen considerably since then. So I'm pleased you acknowledge that, because in the past, I've often been told that the situation's improving, as if that means something, where, you know, if we are still that under the average GP ratio to every other area, well, not every other area, but many other areas, you know, Medway deserves better. That's more a statement than a question, but if you'd like to come back on that. You do talk about partnership working. We, the council, will be one of the major partners, and I'm a little bit concerned on two major issues. One, that you seem to be expecting the council to provide more, especially more social care, and to take on maybe some of the role that we would expect the NHS to be handling. And obviously we don't have the money, you know, well, your budget's being cut, but NHS as a whole is struggling. How is that going to work? And you talk about the work going forward, the 10-year plan. You also mention a 3-year plan and a 5-year plan. And I know it's not in your control, but with the government reorganisation, from our point of view, we've got elections in 2027, which will probably actually happen in 2028. Then there'll be a new authority running the Great North Kent unitary. That will take a couple of years to settle down. And then you're 5 or 6 years into the 10-year plan. The 3-year plan is already well in the past, and the 5-year plan just finished. How difficult does that make it for you and for us to have plans when they can be changed at each stage of that? And I do have plenty more questions if I can come back later, but the simple ones to begin with.
Over to you, Alan.
Thank you. So I'll do them in reverse, and I'll do GP numbers, but ask Suk just to come up with a bit more detail. So first of all, let's cover off the local government reorganisation. So in a discussion across both with leaders and chief execs of both local authority areas, I think we've
Adam, can I just ask you to pull your mic towards you for members, just so they can...
Sorry. So in discussions with both leaders and also chief executives of the local authority areas recently, we've talked a lot about there are all these plans and local government reorganisations. So there is a risk, isn't there, that we don't do anything, waiting for everything to come together. So the very clear view is, in line with the 10-year plan, I think we're really clear, neighbourhood health, where communities live, is really important to get right. So what are the features of that? A really strong and viable primary care offer, what is the clear response to community services in that area, and what is good access to urgent and emergency care. Frankly, whatever the ICB restructure looks like, LGR, that still needs to be in place kind of regardless of that, if that makes sense. So what we've said is we'll therefore focus on the neighbourhood offer first of all, and then as LGR becomes a bit clearer, we'll then be clear about how we come together to work in whatever footprints are decided at that point. In relation to that, though, there's 10-year plan, there's a 3-year plan, there's a 5-year plan. It can be confusing, right? I get it. So let's be really clear what has to happen. There is a 10-year plan, political mandate, we have to respond to that. The 5-year plan has been set out as part of a medium-term planning for all health systems across the country. The reason I've gone for a 3-year detailed plan for us locally is because of the issues we find ourselves in terms of the money and the performance. And having agreed with all the organisations in the NHS, we feel that we can start to demonstrate traction going forward. So I'm confident that as long as each of them are clear where they're going, we can be really clear of the milestones around that. I aim to have the 3-year plan in detail by the end of this financial year, so really happy to take you through what that looks like once that's done, and we'd aim to do that with all partners to get it right. To answer your question, what we're expecting the local authority to do, if that's covered in my report in that way, then I apologise. I would expect us to work really well as partners, as part of a health and care system. So in terms of that, I look at the numbers of people who currently are what we would call a non-elective admission, who basically are waiting in hospital to be admitted or get admitted. I always ask the question, of those, what could we have done differently as a health and care system so they never got there? That requires robust response to ambulance services, robust response to primary care, and really strong social care in the community to keep people at home. Another bit I look at, when I describe the money of the NHS, I'm always really clear that if people are waiting in a hospital bed, we would call them a no criteria to reside patient, a patient that's waiting for onward services. We are spending money on those patients today. So my question is, across our health and care partnership, what could we spend that money on better to therefore get that right? And if we feel that social care or a different model, we should therefore do that together to get that right. But also, I'm really clear, we've each got to try to deliver our statutory responsibilities to the best of our ability. In terms of GP numbers, I've asked many people around the system, can they give me a diagnosis as to why they think Kent and Medway globally is below the number? Many people have given me a view. It could be about deprivation, or about coastal areas, or about the fact that some of the practices don't work. What I'm commissioning is a piece of work that gets to the bottom of that one way or the other. And we'll have that via what we would call primary care network level to understand why in that part of the health economy are we unable to get GPs in place. I'm doing also the analysis on the amount of money we spend across the health and care system, and one of the features that we're establishing is we spend lower on additional services in primary care than other health economies across the country, which tells me there may be a further investment profile to get right. That has to be seen against the context, though, that we do spend more per average patient on hospital services, so I've got to find a way to move the money from there to invest in primary care, and that will be the route through to increasing the GP numbers. But your specifics, so because you're leading the work, do you want to give some feedback on the work at the Health and Wellbeing Board?
So I know, Councillor Wadder, we've had conversations over the years on this topic quite a few times, so I won't go over some of the other things that we've done historically, but I think it's just important to set out context of the conversation that we did have at the Health and Wellbeing Board. I think one of the most significant things that we're trying to do is, I guess, when we develop our neighbourhood healthcare models, GPs are at the centre of that. And Adam's quite right in terms of the solid foundation that we've got. We're having a modern general practice offer. It's kind of the infrastructure that we want to build in. In terms of the GP numbers that were presented at the Health and Wellbeing Board, you'll notice that there was an increase of 5 whole-time equivalents, but actually the headcount was 20. I think one of the things that that's showing is that people want to be able to work in a slightly different way to what they have done historically. So people want portfolio careers. So they want to be able to spend time in general practice, but also work in other settings that give them the opportunity to use their different parts of their skills and ability in a different way. And I think actually the neighbourhood healthcare model that we want to develop will help and enable and facilitate some of that. Some of the things that we want to be able to do, and this might come out through the report, is actually look at what's our USP? What can we offer in Kent and Medway that is different to other areas, and in particular in Medway, that will hook people to come and work here? Because Adam's right, there might be challenges around people's pull into London, there might be challenges around certain areas in deprivation, but actually what we want to do is be able to create our own USP that we can offer in our system to bring GPs to want to work within Kent and Medway. We're working really closely with local medical committees, so they give us some insights into what it is that people want. So is it around work-life balance? Is it around that portfolio career? Are there other things that we could be doing as a system that helps create an environment that GPs want to come and work in? And we have learnt through some of the other stuff we've done. We've done a GP attraction package, which we worked really closely with the council on to try and see what we could do to offer an opportunity for people to come and live, work, and stay within Medway. And the other thing was just mentioned is there's also another wraparound support that we offer, a new to practice programs, how we support people when they come into the system, kind of create that peer network and infrastructure that people feel like they've got some supports. So there are lots that we do offer, but I think the diagnosis of the program that Adam's suggested will help us to hopefully get to the root cause of what it is that's causing the challenge around recruitment numbers, but also what it is that we could do as a result of that to bring more GPs to come and work within Medway.
On
Go on,
that,
Dave. Go somewhere.
just on GP numbers, the PCT, so I can't blame the ICB, but I'll do my best. They did not like single practice GPs. Now I know this is historical, but I do think by closing down those practices, which I know was not direct, they closed them down, but they discouraged them so that they could not be sold as businesses, so you did not keep GPs in the area. And I still think there's, well, I'm aware of a couple of GPs whose sons are doctors, and they will not go into becoming GPs, especially within Medway, because they still feel that. So, you know, that's a couple of people, and I would know those people because of past comments, etc. But I do think that's a historical problem, which is one of the reasons of why we are going forward. There's nothing you can do about that, but just a comment which Sue may know something about and may pass on, but yeah. And with the NHS helping fund the social care side, I was thinking more of the care homes, and some of the people in care homes that have medical needs that we end up paying for, and there's always an argument of who pays what. Yeah, if you want us to take more responsibility and more people out of hospital sooner, that needs to be looked at again and more favourably towards the council, in my view. But thank you.
So just to respond briefly, so on the GP numbers, so I think, should we commit to we'll bring back the report that analyses what it says. So I've heard a very similar narrative for Medway that you've given me, and whilst they're all really helpful insights, I'd like to know, like today, what is stopping this happening? Is it because there's no access to capital? Is it because there's a challenge about available facilities? The other issue is, having spoken and worked with primary care and GPs for a long time, GPs tend to want a very different kind of career. So what is the best model for that for Kent and Medway? But I think we should agree to do two things that's helpful. One is to actually have the analysis of what it says, and then also then what is our recovery plan to therefore respond to it. I think that kind of needs to be where we get to for that. On the social care element about care homes, so the piece of work we want to do is look at what we call are the top 5% of at-risk people in the community. So standardly across Kent and Medway, we're expecting that the neighbourhood model can therefore say, we believe because you might have multiple long-term conditions, be in a care home or be at the end of your life, that there is a greater risk that you may require additional services. So if we know who you are and we intervene early, our strategy would then be, through the use of the community services procurement and also the work with primary care, how do we hold you in the community, give you the right services, and therefore minimise you going to hospital? Because if I can demonstrate enough people can be restricted, I can then change the amount of money I'm giving to acute contracts to reinvest that in the community. And whilst that may sound, all theoretical, other parts of the country are doing that. So therefore, it has been evidence-based to do that. So therefore, I think we need to start doing that in quite robustly here in our system.
Thank you, Councillor Wiley. Councillor Campbell.
Thank you, Chair. Adam, welcome. And I just want to say, I want to compliment you, first of all, on the report. I noticed a distinct difference and improvement in what we have received from the ICB previously. I felt there was a strong narrative. It was structured well. There was an openness to it. And I also note that you acknowledged that historically there's been some problems with how much HASC has been kept involved and updated. Thank you for doing that. That's good to hear because through everything that we've been through in these meetings. So thank you for that. And it's been bolstered, that sort of openness and transparency has been bolstered by what you've just said in your introduction. So it's a great start. Thank you so much. I mean, but wow, what a task to undertake, what a task you have. But I want you to succeed. I want you to succeed in your role because that means then my constituents and my residents benefit from that. So I wish you all the very best. And please do come back and ask us what we can do to support you because we'll be right there with you. Talking about the magnitude of the task in front of you, you're talking about 300 million deficit and your operational budget halved. Wow. I mean, I just want to ask, have you taken on something like this before? Do you have any experience tackling something of this magnitude? And the second part of that is, for me, my concern is your staff, because a lot of Medway residents will be your staff. And this news is all in the public domain, so I can't imagine what uncertainty people would be going through. And I've noted in the report that you've referred several times to support that you have put in place for staff. You've got a group, including you're consulting with unions and staff groups. So that's really positive. But I wonder what the staff morale is like and how does that support actually look like in real terms? How are they feeling supported? And of course, then there's the service users. Through all of this transformation, do you absolutely feel confident that they will not feel the brunt of this absolutely brutal kind of reduction in operational funding? Is that okay? Can I reserve my right to...
Adam.
Thank you, and thank you for your opening comments. It's very welcome. But let's cover that. So the only way that I want to lead an open organisation and an open health system. Frankly, my experience, having been a chief exec, and I've only ever done turnaround jobs, and I'll come to my experience in a second, but for over a decade is, I'll be really frank, we can be really open with you because your constituents will be really open with you every single time they speak to you. So actually, what more can we do apart from say, what you're hearing a thing. Are we getting it right? So in terms of how we're working, and that will be a cultural shift for the ICB as you covered, but the team, have been briefed about all of my expectations about how we work with all of our partner organisations and the absolute respect of the role of HOSC. It is a part of the statutory makeup that holds the NHS to account, and we have to work in that way. So I'm very clear in my position related to that in general. My experience, so I trained as a physiotherapist. I worked predominantly as what you would call a provider for many times and worked at a senior level in that area. And then I've been a chief exec in 3 different health economies, and this is my 3rd. And I'll be honest with you, probably the most relevant experience for here was I led the Sussex health system for 9 years. And when I went there in 2016, it was ranked the 2nd least performing health system in the country due to a number of reasons. Predominantly based on the money, the culture, and also the performance wasn't where it needed to be. So you can kind of see why when I was asked to come to Kent Medway, I felt I had transferable skills that I could bring to bear on that. I don't think it should take 9 years, let's be really clear, before recognising the comment about the 10-year plan. But it will take a bit of time to get this right. What has my experience taught me about how I'm approaching this? This has to be done in true partnership, and I'm one person, and therefore trying to shift a very different way of working. What we need to do in our health system for things to improve is we need the people at the front line to do something different each day to deliver our strategy. So my approach has been to work really closely with the chief executives of the trust and to start to build a relationship with primary care leaders, because all of us together need to lead our people to do things differently. So, and therefore, I think if we can get that right, we can therefore start to attend to what are some of the financial elements going forward in the system. But I think it's really important that the NHS can present one version of the truth about why it is where it is. So I've got, you've seen in my report, many views and thoughts of it, but I want to be really clear. What makes up that £30 million deficit? Is it productivity in organisations? Is it how things are configured? Is it that we've spent the money in the wrong place and therefore demand moves? The reason that's really important for me, if we don't have that and don't have that fully agreed, everyone's running after a different ball and we've got to run after the same ball together. So that's kind of my approach going forward. And we will call it a drivers of the deficit, which is basically why are we in this financial position that we're in. So I'd aim to also share that with you because it will be in my public board papers. I aim to take you through it to explain why that's the case, because it will also help me to explain to you why I think we need to make certain decisions in the system. At times we might disagree about those, and that's also fine, but my approach will always be to brief you early, so therefore you know in good time to get that right. Our staff, so you'll be aware of a cultural review into the ICB that, you know, when I read it and was given a briefing of it, I genuinely felt quite sad reading it for the people there. And I've come and I think we've got a sense of structure and there's a sense of increased energy in the organisation. All that was going pretty well into 4 weeks. And then, of course, I had to announce the voluntary redundancy scheme because the money was allocated from Treasury. So you could imagine, we've told the organisation in my 4th week that we need to reduce the headcount by half. Now, they knew it was coming, but you know, when it actually happens, it has a deep effect on people. The actions that I've tried to take is to preserve as many jobs as possible in that. And one of the actions that I've taken is to consider, I haven't yet got board approval for it, but once I have, I'll let you know. The all-age continuing healthcare services and also our meds optimisation teams, they're very clinically focusing services. So therefore, it's my current view that we should therefore transfer those staff to a different organisation to lead and manage them. It preserves their jobs, but most importantly for our community, it also preserves those functions working well for them. That should help to minimise then the numbers of staff reduction I've got to deliver in the organisation, but it is important to state we still need to reduce the headcount by half. We've launched the voluntary redundancy scheme that closes next week. We should then be able to be clear what people have said on that. If we have enough voluntary redundancy applications, we can therefore kind of move on. If we don't, I then need to launch a compulsory redundancy scheme within the organisation. So you can imagine, if you work for us, people are worried and anxious. I think we're doing all the right things, which is regular communication, keeping them briefed, all those things. But we're constantly checking, and you know, in my inbox is flooded every day by people's thoughts and feelings. Some people like the direct view about, at least I know what's going on. Some people really don't like it. It's like the natural human variation, isn't it? But I think globally we're getting a sense that I think we're handling it as well as we possibly can, but we've got to keep an eye on it. And yes, you are quite right to say some of them will be your constituents, and therefore you've got to support them well. The service users, so it is really important that I'm re-looking again about what is the natural engagement strategy for the organisation. Does it make sense? Do we listen to people, you know, in their communities? How do we do that? What's the approach to get it right? But I think there is a significant risk, in my opinion, if we don't engage people on this change, that actually it becomes quite jarring as we begin to implement it. So I haven't yet got a model which is the best way to do that. And I'm aiming to discuss that with our board next week and then give some thoughts to partners about how should we best approach the engagement. Because in reality, I need to tell the population of Kent and Medway that we're currently spending too much money and we've got to spend it differently. So how do we make choices together for where we spend the money? And that might mean things change for you locally to us. So we've got to find a way of having that conversation and with the best respect, not doing it in a sort of level of management jargon that people can't understand or can't penetrate. So that's kind of our approach. I think it's a fair challenge, but I think I've got more work to do on the service user engagement. I'm very happy to come back to the committee at a later date with our thoughts on that.
Thanks, Adam. I'm really glad to hear you're looking at potentially overhauling how the engagement works, because in my experience, both the council and the NHS, that engagement just isn't a strong skill set for us. I think all the engagements that are out there, very few people actually engage with it if you look at the subset of people, of your service users. So I hope you can come up with some creative solutions as how to actually involve more people and bring them along with you on the journey. I just have two questions. I'll combine them and then you can answer however you want to. So when you said that there was some, in the procurement of the community health space services, you said there were some services that didn't fit in with the brief of what you've procured now. Now, when I read that, I expected them to be, I mean, all medical needs are important, but I expected them to be perhaps lower down on the hierarchy of need. But then I read that, and it's quite alarming. It's dementia services and end of life and, you know, triaging for people with chronic, difficult, complex health conditions. So that sounds pretty life-limiting, those things, you know. So I don't understand why they could not be included in your current brief. And once, I mean, you say you have a plan in the early part of next year, you're reviewing it and you're going to come up with what to do. So to avoid something like this before, could they not be absorbed in what you've already got going? Because that's been quite a massive exercise to put it in place. So that's my first question. The second part, I'm going to be cynical about this. I've read so much about the neighborhood plan and it all sounds amazing. But very recently, we had what sounds like a neighborhood plan to me, to open a facility at the old Debenham site in Chatham at the shopping center in Pentagon. I've been to meetings where, the council was fully on board. Senior council officers were there, the MFT people were there, and ICB people were there, and everyone was like, yeah, this is a great plan. Let's take the pressure off Medway Hospital. Let's put more elective surgeries and, non-urgent procedures here in this place, in the heart of the town centre where people can access, maybe a couple of GP practices as well. That's what the neighbourhood plan is. That's effectively what this is. And I thought it was just a matter of lining all the ducks up in a row and then it was all, but now it's not going ahead. And I don't know who pulled out of it exactly, MFT, ICB, but it was an NHS body who's pulled out of it. So, lots of plans and lots of projections and things, but we need to see stuff like this progressing. We need to see it working. And that was a wasted opportunity. And I know Councillor Field will tell you about a Healthy Living Centre that never went forward in Strood as well. So this stuff was, Councillor Jackson. So we have had plans around neighbourhood plan before. They've just not progressed. So I'd like to see that some of those wrongs, because they are wrongs against the community, that they're righted in the coming years. Thanks.
Adam, just to say, it'd be quite good as well for our MFT colleagues to hold that question as well when they come up here as well regarding Debenhams, because I know they're heavily involved in that. If you just want to answer briefly on that one, Adam.
Yeah, sure. So I think, first of all, on the community service procurement, your questions are the same for me, to be frank. Why is it not on the same place? I think the team are now working to resolve that really quickly, and I'll bring Suk in to give the detail on that. The reason for that is the board made that decision before I was here, but I've now got to try to resolve it and get it right going forward. On the neighbourhood plan element, having looked at all of the schemes, there are a number of schemes across the whole system that I need to be really clear are financially viable. So I think what happens is a number of discussions are held and then it requires the financial investment to make it work, and it then gets quite challenging at that point. So for each of the neighbourhoods that we agree, we've got to be clear what is the neighbourhood model. So is there going to be a physical facility in each neighbourhood or in every third neighbourhood, and what does that therefore look like? So what has worked in other parts of the country and other areas that I've led is, first of all, there's a clinical model that is agreed, and primary care are the ones driving that. So therefore, they're the ones who want to bring activity out of the hospital. And then what you then do is you cut the acute hospital contract and you move the activity into the community. So that's what we need to do to get right. So for that scheme to work, it needs to make sure that it works financially. I've asked the team to do a rapid review of why that is the case and what's happened for that. And I'm sure my MFT colleagues will cover that, but that aims to report to me at Christmas to therefore be clear about what needs to be in place to therefore get that right. So that's kind of our approach on that. But on the community services procurement, because I think there are particular questions you want to ask, Suk, do you mind just coming with that?
So, as Adam mentioned, we reviewed, I guess, what goes into the core community services contract. As you can imagine, we looked at there was differential services in different parts of the county. So we've got the core community services contract. I think the important thing to note is that when we've looked at these outer scope services, or we've deemed them as kind of outer scope services, what we now need to look at is how we sustainably commission them. So there's three options that we need to have. Actually, if these are services that are really important for the community, and again, taking the approach that Adam mentioned earlier on, looking at strategic commissioning, what's the population health need? Do they deliver the outcomes for the population? Are they the right services that we need to commission? We then need to look at how we commission them sustainably. If we look at that, there might be some things that we look at and actually we could do this better. We could do this differently. We could redesign them. We could think about what we need to do around neighbourhood healthcare. Is there an opportunity to try and shift some of the services into slightly different settings, to take care out of hospital and put it into the community? So there might be an opportunity to redesign them. If we go into a decision that any of these services would need to be decommissioned, we would need to make sure there's clinical engagement in terms of what we do, there's stakeholder engagement, so we would work with obviously the Scrutiny committee around that, but again it would be based on the fact that we can demonstrate that there are effective pathways already in place for patients, there are alternative services that support them better than what we've got at the moment, and it would only be on that basis that we would consider decommissioning them. But as I said, that we haven't yet come to form those decisions on which of those options we may take around them, but it will be the robust process around our strategic commissioning approach that Adam mentioned that we will take to help inform that.
And just to come back how I can on that, I think what's really important, it's a bit of a test now, isn't it? These were out of scope, so how are we going to be clear how that works with you and in a really transparent way? So I think it will be a really great test of the things I've said, actually does it work in that way? So I think if we're happy, Chair, that I'll take away the action to work with the team to make sure we're really clear of the route map we're going through, what the decisions are in the ICB and the dates for them, and how we can demonstrate really strong user and also clinical engagement in that process so that whatever we decide, people feel that they've had the chance to input in, shape and get right. But if we give ourselves that challenge, I think it will help to, I think, hopefully kind of demonstrate a thing that we're doing differently to therefore try to manage in a different way.
Thank you, Councillor Campbell. And hold that question, hold that thought for the next one. Can I just remind all members, and especially those answering, can we just try and keep the answers, time is on us. Councillor Cook.
Thank you. Firstly, just to echo Councillor Campbell's welcome. It's really lovely to see you here and welcome. Hope you enjoy working with us. And also, I totally agree about the report, and it was a fascinating read, quite a sad read in terms of the statistics. And I think I actually stopped and gasped at the 12-year lifespan gap in coastal areas. That is shocking. And it really made me think around, you know, and really stark about how significant this work is now, as well as in the future. And you've already started to talk lots about that, and you've only been here 5 weeks. But I think it was that page 2829, 5.3, and it was those words, reset, recovery, transformation, that I kind of read the report and then went back to those 3 words and reframed my understanding of the things that you were saying in those words. And the words I wrote was mitigate risk. And exactly as you were just starting to say around, you're doing this essential work, that's the situation's only getting worse. It's only building up, you know, critical care needs delivering now. Unfortunately, we can't stop the world, make things right, and then start the world again. And you've got to halve the budget. So can you talk to us a little bit more? There's lots in there about governance. There's lots in there about, and you've spoken about engagement, but what are the ways that we're mitigating the risk of things being lost and being missed and getting worse while this transformation's happening? Thank you.
Shall I give an example about cardiovascular disease? So looking at what I call the QOF data, which is the data for primary care, looking at hypertension rates, lipid management, AF, so atrial fibrillation. People speak a lot about, you know, reconfiguring stroke services and where the best cardiac units are. I'll be frank, primary prevention would be the best thing that would keep us all very healthy and well now. So I do think there are things that are already in train that we should therefore amplify together. So to be really clear, if we could increase the at-risk cohort of being diagnosed with hypertension and being treated well quickly, that would already start to attend to some of that demand we're talking about. If we were to focus that then on our LSOA areas with the highest deprivation scale in Medway, that would actually also begin to attend to the 12-year gap. So I think there are things that we can therefore do, but I think there requires an element of focus across the health and care system on what are those 3 things per neighbourhood that we expect to be in place and working from April. So I think there are certain things, yes, of course, a new building, transfer. So back to the earlier bit about what you could do on the Debenham site. All great and exciting things, but I think there is a challenge to all of us. What are the things that we could be doing now in the reset phase of the things that could get better? So I think, and when you look across the system, I could go to severe and mental health assessments for people that need their physical health checked. If you've got a learning disability, is it right that, you know, just under 2/3 get an annual health check in Kent and Medway? No, it's not. But what do you think happens to those people when they then don't get one? Their life-limiting conditions get worse, you know, all of those things. So I think we've got to be quite challenging of ourselves about there are things we have to do for the long term, but there are things we could just tackle really, really clearly together. So what I'm challenging my team for are, what are the health improvement things that we could just amplify now and really push, and then you can get a bit of public awareness around it to therefore manage it going forward. So I hope that gives a sense of, I know a lot of this can feel what's happening in year 3 and year 5. There are things that can happen in 3 days if we all got together and agreed the approach to get it right. So that's kind of the spirit in which we're trying to manage and lead at the moment.
Thank you, Councillor Cook. Councillor Jackson.
Thank you, Chair. And welcome, Adam. And I don't mean this to come across harshly in any shape or form. Keep that smile on your face. But we got frustrated with the transparency, and I think that this is a line in the sand and we're going to move forward. But I have my ward surgery next weekend, and I know there's going to be over 10 people waiting there for me to say, what's the update on the Healthy Living Centre in Strood? Like when you say about what your residents, and you hear your residents, that's, I know, and I've had to walk in there every month and go, now they need some, like it's past history, they still haven't been given a proper apology, a proper explanation. I mean, we have sort of, but they haven't. And when you talk about engagement, they are still angry. Like they is still there. They feel that they were robbed of it. They had letters saying that the money was there. They feel that I still have that letter put under my nose every single month. If we want to be transparent and bring this to an end, we need to be really positive and engage with them.
So just for a slight overview, Adam, there was a question from the members from Strood about the Healthy Living Centre, the lack of a Healthy Living Centre. It's in every other town in Medway, bar Strood, and let's not forget the peninsula and the rural areas as well, poorly served. And the reason they got was that there was money there. They were told there was money there, but then that money wasn't used and it was moved to somewhere else. So you can imagine that we have reopened it. It's not stopping and many people that were involved in that have now gone. Those in the CCG and those, you know, as you know, in your, as you call it, in your economy, everyone moves on, or they're from past and they move on somewhere different, and then you can never pin them down. I think it's a really pertinent point. I'm not sure you'll be able to answer it all this evening, but it is a pertinent point that I do think we need sorting out. And you know, so there's loads of parts around that. It's the pharmacy, it's the GPs, it's the Healthy Living Centre. But it is frustrating. That is part of that transparency.
If I could, I mean, that is it. I mean, you sat there and asked what our residents are asking us, and I'm telling you.
So first of all, I find it really helpful to have this conversation. So no apology for at all. It's fine. Look, I'm 5 weeks in. I think, you know, what I need to do with the Office of the Council is kind of get like a list about what are the things that just need dealing with and being really clear about. I think because what my sense is, a lot of these things have been going on for a while. They might not have felt locked down. If I need to come and speak to people with you, you know, we can do things together just to try to manage it. But I think I'm with you on the drawing the line in the sand, but I think what I'd really welcome is if there is a list of outstanding issues that need to be dealt with, whilst I can say I wasn't here, I am now the Chief Executive that has to resolve it. So it'd be good if we can get that list together to kind of nail, so that we can be clear what I can agree to or not agree to, but just to be kind of straight down the line about where we find ourselves, I think would be a helpful way to sort of take us forward.
Thank you, Adam. I mean, I do think they just want some answers. I feel like they just feel like they've been left in the dark. I think that's it. So I think, you know, just communication would be a start, really. Thank you.
And I know Lauren, our MP over there, is talking to you about that as well. So I think that's, yeah. Thank you very much, Councillor Jackson. Councillor Shocker.
Thank you, Chair. Welcome, Adam. So VCS partners will play an important role in all these plans. And if they're utilised correctly, could save the NHS significant amount of money going forward, a lot of it through prevention. However, how are you going to ensure they get a fair deal in all of this, especially with the reductions in costs that you're looking to make? What's really happened in the past is lots of partners rely on their good nature to support their communities, rather giving them a fairer deal for their organisations and the employees that work there.
Thank you. So I'm working with a team to understand how the VCSC kind of sort of makeup works across the system at the moment. If I give you a sense of what I've done elsewhere, that might give you a sense about how I approach it. So looking through the return on investment for most VCSE organisations, they can do things really quickly, really agile, at a very low price, to be frank, in terms of comparing to non-statutory services or other statutory services. But what they've often told me in different roles is the long-term funding settlement for them is really quite important. So kind of going hand to mouth on, you know, year-to-year things is quite unhelpful for them as a sector going forward. So in Sussex, I commissioned a voluntary sector alliance that basically treated the coordinating chief executive there was treated the same as the chief executive of one of the hospitals. And therefore we made decisions in that way. That may not be the right model for this health system, but I hope it shows my commitment to making it work with that part of the sector. And we funded them for their administration costs to be up and running and therefore get there. And we gave them a 3-year contract. So therefore they knew what their funding was. Now, like everybody else, into year 2, we negotiated it again going forward, but we did it in good time to get it right. And the feedback I've had is that there's a vibrancy of that sector across Kent and Medway, but I think what's important for us is to be really clear about how we dock that in. And of course, the sector here operates at different levels, doesn't it, in terms of the size of organisations. Some are really very local and some are much bigger. So one size doesn't always fit all, but I think creating what is the ICB's offer and how we want to work with them and being clear on that, I think, is key. And the job I've got to do, which is my responsibility because I haven't yet had the conversations, is to also speak to officers in both councils about how would we best work with you in a joint way or a non-joint way to get that right going forward. So they're my initial thoughts, but I think I'll need a bit longer to work out what the best approach is to therefore work with them going forward.
Thank you, Councillor Shocker. Councillor Howcroft-Scott.
Thank you, Chair. Welcome, Adam. Good job you're still smiling. You know, 14 years of a Tory government, you know, the NHS is on its knees. But I'm here as Chair of Children's, but I'm just subbing this evening. But engagement is what I want to ask you about, because children have many lived experiences. And when I do my ward walks and site surgeries, I have such a dichotomy of experiences. So what I feel you're picking up are some islands of excellence in a sea of indifference. So I want to know how you're going to change that. I also want to know how you're going to engage with our wonderful 63,000 children and young people in Medway, and how you're going to embrace their lived experience, because, as you've already said, prevention is better than cure. And then my final question to you is, by April or the end of the financial year, can you give me any tangible differences you think you and your team will have made by then, please?
Sure, let's start with the C, if that's okay. So yes, there are pockets of brilliance that are happening in the system, but is it happening standardly? No, it's not. So for community health services, and by that I mean all age health services for children, young people and adults, there isn't a common service specification for that is clear about what is expected in each of our neighbourhoods across the system. So that needs to be really clear. So what is the offer that, regardless of where you live in our patch, you get in a standardised way going forward? So that's kind of the aspiration for where we want to get to. What that therefore means is there also needs to be a targeted offer, because different parts of the patch require different elements depending on the demography, what actually happens in that part of the health economy. So I think that's kind of the approach we're looking to take, not to homogenise everything, but to try to bring everything up to a common standard. So therefore, wherever you live, you get a common approach. In terms of engaging with children, my views are that our young people can have and can give us quite a profound kind of challenge to how we therefore work. So in previous roles, I've worked with youth councils about shaping services and getting that right. You'll be aware, and I'm sure it will come up later, about the decision taken by the ICB to therefore bring the children's mental health services into our mental health trust. What I've asked the trust to consider is, what is the approach with our young people that will tell us, is that working well, what can be different, what are they looking to achieve in terms of their emotional health going forward. And then globally, what will we have achieved by April? Well, frankly, I'll have had to first of all be really clear about how I've managed the financial deterioration of this system and landed a position that is therefore acceptable both to the government but also to us together. And I think that is a major thing to resolve quite quickly for the NHS here locally. The second thing is when I look at winter and look at where things sit, what do I expect to have seen happening? Well, I expect to have seen all of the people waiting over 65 weeks to be seen and to be dated and for that to be delivered. When I arrived here, I was not confident about the plan. I'm now increasingly confident that will be delivered by, therefore, the actions and questions we've asked of people to therefore get right. I expect to see a reduced demand referral rate from primary care by us putting in different care pathways by April, because in reality, if we don't do something different by April, the 225,000 people on the waiting list increases to nearer 248,000, and that isn't right. So therefore, I have to do something to attend to that to make sure people are seen quicker. And then the last bit, I think, which is really, really important for me, I have to make sure that where I hear that services may have challenges and problems, they're resolved. And you have an agenda item later about mental health. I'll need to make sure the mental health improvement plan is delivered, so therefore there are safer services and that the quality improves in that space. So they're my areas of focus, and of course I'm sure, having taken the tenor of today's discussion, nearer April you can judge me on my performance against that, but they're the things that I expect to see improved in the system, and all organisations have been made very clear of my expectations to do that.
Thank you, Councillor Scott. Councillor Perfect.
Thank you, Chair, and thank you, Adam, for coming along. And can I thank you, I think, for your very transparent way in which you've approached this committee this evening. I'm very impressed with the report, the openness and the frankness of the conversation. And I think, certainly from what I'm hearing, both from stakeholders within the council, but also from other councils across Kent, I think your openness and willingness to be frank about where the ICB currently is, but also the challenges that face the system in Kent and Medway has been well received. So I'm very grateful for that. As well. Just in terms of a couple of things for me, I'm not wanting to go over other things that people have already commented on. I mean, for me, I'm just very interested from you about sort of, I guess, your strategic view of the organisation, not necessarily the sort of 5 to 10 year plan or the wider business plan for the organisation, but obviously coming from Sussex, sort of and you've touched a bit on it, but particularly through the lens of integration with the council, just in terms of how you might see that working, in terms of how you think you can bring, not just at a senior management level, but at all levels of the organisation, you can bring a much more sort of joint public sector approach, I guess, that I think other ICBs around the country, particularly those that are very high performing, there's that almost sort of, I don't know, brother and sister type relationship between the council and the ICB and other parts of the sort of service. And I think, you know, this council, through its One Medway Council plan, is attempting to move in that direction, obviously noting Councillor Wildey's points around local government reorganisation, but I'd be interested sort of how you sort of might see that working. And then the second piece follows on from the question really about leadership and culture earlier on. Obviously, the pretty damning report that came out under your predecessor very recently, just before he left the organisation, that was all over the the trade press and everything else. I'm just interested in terms of how you're finding where you're at. We touched on this the last time we had a meeting, I think, a couple of meetings ago. This committee, we asked some questions around that, but I'm just in terms of any sort of learnings that you are attempting to bring, or any sort of anything you think that you haven't already mentioned might be relevant or of interest to the committee around that, because I think culture in any organisation is absolutely key, and some of the findings in that that were printed were pretty damning. So thank you.
So I've worked across the country, had a national role. My view of the integration with local government is, I think it's okay, but it could go further. But that was what I'd always say in most places I've been. What do I think we need to be a bit stronger at, I think, in this health system? I think being really clear about what other things we're going to work on together, and then can we back that? I have been given quite a lot of openness from my council officer colleagues about some of the frustrations that they have had working with the ICB. I think a lot of that is fair. Some maybe not. I might have a different view, but they're by the shouting, I think. And that's partly because I don't think we've been clear on our long-term vision. So that's why I'm trying to lay down track on neighbourhoods is where we're at. Because I think for most local authorities that I've worked with historically, it's what the constituents are saying. So neighbourhoods, communities make sense to folk, really. So therefore, and it kind of makes sense to primary care too. So we've got more in common. But I think what we're going to have to be really clear is what is the NHS going to formally offer to the Medway plan? What is its give? And therefore, can we be clear what it is and what it isn't? So there's no ambiguity. We can talk about that and debate it, but getting that right. What I'd also say is recognising, I recognise, it's not our job to get involved in local government reorganisation, but I've worked in many different health systems where I've had, so in Sussex, I had East Sussex, I had West Sussex, and I had Bright Ellen Hove. And we found a way to work with different size authorities in a way that was respectful. Some things we did once because they made sense to do once, and some things we didn't. So I think, I think it's really important that we recognise the identity of Medway and we work really hard on the Medway plan. Leadership and culture. So what have I seen? I would say that what is in the report I've seen in the organisation. So I don't sit and come and go, I think the report was wrong. I think it's pretty accurate from my perspective. Three things I speak to the organisation about every day, about what I expect. First of all, I expect open and inclusive behaviours from everybody. That's at every level. My level, all the way into the organisation, that's clear. And we have to constantly guard that. So the moment someone is not aligned to that, it needs to be managed sensitively, but managed. People look to when things get left and not attended to. Second bit, there are within the organisation, there have been historical issues about racist, sexist and homophobic behaviour. That needs to be managed too, really, really quite carefully, in a culturally competent way, but dealt with. And then the last thing is what is really important, as difficult as this message has been to give to the organisation, and back to the earlier questions that Councillor Campbell asked about the morale of the organisation, we are here in service to 1.8 million people. So it is important to remember our core purpose. And that is why we are coming to work. And sometimes cultures, when it becomes quite damaging, it then can become about how people are feeling, which is important. But what I've tried to inject is, what are we doing today that makes things better for our community? because I don't know about you, but that makes me feel better too. So how do we therefore get that right? So that's kind of the approach we're taking. And we're doing monthly pulse surveys. Our most recent one was in. It showed a much better engagement score, much better positivity, but it's been a month. And we've now got to deal with VR. So I think there's still work to do to get that right.
Thank you very much. Thank you. All done. Okay. Did you come through, Councillor Nain?
Well, thank you very much for your brilliant explanation. My question relates to the neighborhood transformation. Basically, we are talking about 50,000 people to bringing care closer to our homes. Currently, with the ALGI, our local government reorganization going on, how will you ensure that local residents and communities will have their voice when it comes to the activity involving the reshaping and bringing the neighborhood, the NHS closer to the local communities within Medway and other areas with regards to the local government reorganization?
Yeah, so I think that goes back to my earlier sort of answer. We're going to have to reshape the health system with our communities, not to our communities.
Councillor Nain, can you just turn your microphone off? Sorry, Adam.
Sorry, with our communities, not to our communities. How we go about doing that, I want to take some time to get that right. There are some ways you can false start that one, and I want to be really, really clear how we're going to engage on this change, both with our local authorities and also with our partners. So I think if I can take the question away, work out what the plan will be, and come back in due course with our strategy about how we'll approach it, that will give us a time to get the engagement approach right as we start to shift this going forward.
Thank you very much. Thank you, Councillor Nain. I've got a few questions, Adam. I think you'd expect me to have a few. I think just opening up, though, I suppose you are welcome. We've spoke already before. I think the transparency part for me is the key part. I join everyone in welcoming you. We've had this before, as your colleagues next year will remember. Going at the very start of the community services procurement process, everyone was welcoming the officers and welcoming the transparency and openness, and it collapsed. We never got that through the process. Again, though, that transparency for you and for us has to work if we've always just updated as best you can. You've got enough challenges on your, within your organisation, 49% staff cut, everything else. You've got enough going on. And I think it's taken a little while, not the colleagues sitting next to you for sure, they know exactly how to communicate and work with us. But I think it's still going to take a while for that trust to be there from the ICB side with us and us with the ICB. And it happens, we talk about the community services procurement, and I have to mention again because members did, we find out from an external member that the out-of-scope contracts were signed off with just days to go, 40 odd million pounds worth of contracts. We were always told during that process that we'd be told, And even to today, remember, this committee has the function of SV, of doing our substantial variations. We don't know what you've extended. We don't know what you had to rush through. We don't know any of that. But from a substantial variation on the whole community services procurement, we are supposed to know. And it's just to make sure that it's not to block and not to stop you and not to stop our residents getting the services they deserve. But if it does appear to us, as your colleagues would be able to tell you, if all of a sudden we find out from outside members that that's happened and we're not informed, it can block your services. Because then it has to come back to us, and we don't want that. So I think, I'm not saying it probably happened on the first day you walked into the organisation, but that communication to me and to our members was told to us that was done with and still has not been officially told to us to today. I had a conversation, I know, with yourself and Silly, but still hasn't been told to us formally. So just to start that one off, I think if we mean to go on and be in the right way and to even support you with the challenges you've got ahead of you, then please bring us on that journey with you instead of just hiding us behind the background. Can I just say, though, how are you, Adam, going to protect the statutory responsibilities with that 49% staff cut? How are are you going to learn? I suppose I'm pulling up on what Councillor Perfect and others have said. You're going to take models that you've done before, but 49% of a cut of a service where you've got to look at your staffing, how are you going to make sure it's protected all the statutory responsibilities that we expect of the ICB?
So on the first one, just briefly, I think we've met. We have to go into this with an open reset, but I'm aware trust takes a while on all sides to be learned, and we'll have to find a way to get that right. So so there's a number of things we've agreed tonight. That's hold us all to account, isn't it, to do it? And if we do it, then we can all say we've got a list of things, we're working it all through. The issues regarding Strood get resolved one way or the other. All those things just kind of happen. I think that's kind of a test for us, isn't it, really? So let's put that there. The 49% is really tricky, I recognise the Kent and Medway system is unique. And probably every ICB CEO in the country says theirs is unique, right? This one is unique because it has significant challenges that need to be addressed. I've outlined them earlier. But it didn't choose to cluster with another ICB. So other ICBs have chosen to come together, as you'll be aware. So of course, some statutory functions you've got, if you merge them together, you can do them a bit easier because with the best respect, legal services once or twice, you can probably reduce that quite straightforwardly and still deliver your statutory functions. So what I've got to do is be really clear about what other things that need to happen. I'm really committed to ensuring that there's a statutory body at Kent and Medway, in perpetuity, as long as it makes work in the financial way that it needs to. But one of the ways I'm going to look at that is I might need to share functions with other organisations, either in trusts or also in other ICBs. So, for example, across the South East, there will be 4 emergency planning functions. Now, we will still need a local Kent and Medway person, but do we need all the people we've got if we can do some of the corporate things once? They're things that I'm kind of considering. And once we're clear on that, we'll come to you and say, particularly to officers of the council, these are things we think we'll be doing a bit differently. Does that cause any problem for you? How do we get that piece right? That's the first bit. The second bit, I do believe that the role of a strategic commissioner is to it's not to tell the weather today, it's to forecast the weather in a year or two, if that makes sense. And probably my trust colleagues will say they know what the weather's like because they're dealing with patients today, right? But the data we've got available to ourselves, I don't think is used effectively. So I think if we were to look at the data and the insights in a very different way, using public health observatory data, using other information sets, I think it would tell us quite clearly what other things we should be focusing on. So I believe we used to have people who would be looking at all that data, but the use of AI should be able to give us different ways forward. Now that is not an easy message for the 49% of people that we're saying won't have a role, but to how we deliver our statutory functions, I've got to look at each of them and go, what is the most innovative way we can therefore do it to get it done? To answer the question outright though, do I think Kent and Medway can go on its own and deliver it? Yes, I do, but it will need to feel fundamentally different for us to therefore make that work.
So which critical functions do you think face the greatest risk of their degradation in the service? I know you're pushing some out, where you can, and that's really good because you want to protect staff, of course you do. But are there any critical functions that may face risk going forward?
So first of all, if there are a critical function that faces a risk, it's my job as a capital officer to mitigate the risk first of all. So is there anything that I'm particularly worried about? I'm actually worried about I'm not worried about the statutory functions of the ICB. What I'm worried about is, do we have enough people in the system to do the transformative change that I've outlined? So if you imagine, I'm reducing my staff by 50%. Our trusts who we commission services from are also reducing some of their headcount too. So when we want to shift activity from a hospital to a new community facility, someone's got to do that and it not be on top of their day job. Someone's got to get out of bed and that just be their job. So the biggest risk, I think, to the overall transformation programme is having our best people working on the transformation to get that right. And at this current point, Chair, I don't yet have a route to get that right, but that's why I'm working with all of the provider chief executives to work out what could a joint team look like to do that transformation.
Thank you, Adam. And can you provide us any assurance that local commissioning influence won't be diluted during the process?
Yeah, so one of the principles of the operating model, so it goes back to the LGR conversation. So of course we're designing an organisation for now that of course will change. So what I've asked the team in the operating design is to make it clear how do we provide interaction with Kent County Council and also with Medway, but of course we'll be telling our staff that might have to shift if local government boundaries change, if that makes sense. But I can kind of, I'm in the place of I can't wait for that. I've got to do now, but be really clear with folk that might have to change going forward. So I think that should give the assurances. But what we'll be doing is sharing the structures with officers to go, does that kind of work? How are we going to work together to get that right? And already we've had really great discussions with our public health colleagues in both local authorities about how they'll provide resources into our multidisciplinary teams in the organisation to make sure we've still got the right Kent and Medway focus.
Only a couple more from me, Adam. You'll be pleased to know. You're only 5 weeks in. You're not going to be able to say that for much longer, but you're new, right? So you've looked at all, I'm sure you've really scoured and looked at all the contracts and looked at everything you're doing, a lot of the stuff, including the big one, which is the community procurement one. And that's what we've been involved in and totally taken over most of HASC for the last 2 years. Would you have done anything different with, say, the community procurement, the services procurement? Would you have done anything different looking at it now?
So hindsight's always a great thing, right? In terms of, and you get to always come in and go, well, if I were here. So, like, what do I think as I look at it currently? I think it's fair that you would have put all of the services into one tender, I think, and be clear about that. I also think that because we don't yet have an agreed clinical model for neighbourhoods, it's a little bit tricky because I think the contract's going to have to keep evolving as we go forward. So I think what I would have probably wanted to have seen is, have we all agreed the neighbourhood model that this is trying to respond to? Because I also would have thought then the contracting model behind that would have also probably made more sense to folk, if that makes sense. So I think that's the first bit. The other bit that I would have also have considered is this an NHS commission or is it an NHS and local government commission? Because we could have done that bit a bit differently, if that makes sense, in terms of how we. So they're the things that I'm looking at, and how I look at things in most situations is, what is the strategic endpoint we're trying to get? We're trying to get neighbourhoods that are fully functioning and are vibrant, right? That's what we're going for. So my question would always be, what is the quickest route to doing that and the most evidence-based way of doing it? It might have meant that there was a different way of the contract being awarded. It might have meant those things, but they're the bits I think that we've now going to have to retrofit to therefore get right.
And it's never too late, right? It's never too late to change and work with the people that have got the services to change the way the services are going to operate in the future. I think my last one, and my colleagues in KMPT, and they will kill me for that, but the KMMH hasn't really got into my mind yet. But I am going to ask you, I'm sure they know I'm going to ask you, but obviously this committee had a real debate with the ICB and our colleagues over in KMH as well about that all-age children, the children procurement programme. You'd have seen it in the last a couple of meetings ago. So they've now obviously failed, which you'll be hearing us talk about their CQC. Are you still confident that it's the right place for that contract to go from NEF over into KM? I'm going to say KMPT. Are you still confident, especially when there wasn't that expertise and that what this committee brought up? As the commissioner, I'm asking you as the commissioner, because obviously we'll be asking them the same in a moment. but are you confident that that service is safe going over, considering the CQC outcome?
So I'll go back to what do I think is strategically right for mental health services in Kent and Medway. I do believe them being led by one organisation that integrate well across the all-age pathway is important. And there are two reasons for that. One, I think we do have people that transition from children to adults, and I think a smooth transitional pathway works better and it's evidence-based to work in one organisation that have responsibility for that. So that's the first bit. Second, it's really important, isn't it, that the children of those who've got mental health conditions are more likely to truant from school, to have higher obesity rates, and to also have worse economic outcomes. The data proves that to us. So therefore, there is something about if we've got a cohort or an organisation that are attending to the adult needs, they have the ability now to also attend to the needs of the children as part of that going forward. So I think there are benefits to the model coming together. So I'm supportive of the model. You've asked me, am I confident? I am building my confidence on that at this current point. So the first thing is for the adult services, you'll hear from colleagues later, but I've been quite clear about my expectations for improvement in those areas and how that happens. And I'm seeing those improvements come forward, but there is still more work to be done to get that right. My question about the all-age transfer in is do we have the right capacity and the right due diligence done of what the organisation are inheriting? And then it's my job as the Commissioner to make sure I'm satisfied about that, but most importantly that therefore, if I believe there's a deficit, I do something to resolve it. I'm not yet there at this point to know the answers to that question, but I still believe it's the right endpoint for the system. Our job now is to therefore make sure that any risk is really clearly articulated, and that most importantly, we are clear when are the benefits that I've outlined going to be realised, so we can be all clear together about what that therefore means and looks like.
Thanks, Adam. And you know, just following on from that, you do realise that this committee, I'm sure you know this committee had serious concerns, so did our Children's ONS committee as well, about that lift and shift contract and how it was just shifted over. So obviously, I presume you and your colleagues will have assurances in place, and so will, I know, our colleagues from the mental health team be able to talk to us about that, because it's a real concern for us going forward. You've heard everyone now. I just want to reassure members that I know Adam and I are, and the team will be talking about a memorandum of understanding going forward, which should be able to, some of your colleagues will be relieved, not have to stand. We know exactly where we are going forward. I think that's going to be a really good thing to work on and do. But I would appreciate a couple of takeaways from you would be us knowing what those out-of-scope contracts which were done and done very quickly, what they were. And obviously also a plan going forward, so we're prepared of when you've got the year as is coming up soon, and that we're possibly, I don't want to be bombarded with no notice with about 15 to 20 or more substantial variations coming in without notice. We haven't got much on our agenda going forward after January. And if you really, if you know what's happening, please start talking to Terry and us, because we need to plan that in. Because it can be, as you know, I see you smiling, Mark, it can be quite a nightmare for you guys and for us to have to go through that. And a bit of planning would be, so a takeaway for you would be that. My final one would be to have a little discussion about that letter for West Street in, but I know Silk will be able to update you on that after, because I don't want to be coming back here. I don't want to be coming back here next week to say that it's unfortunate again that the trust between the three of us all signing up to something wasn't done. But thank you, Adam, and thank you, Silk and Mark. Mark, you're staying. I'm coming over to you now. But thank you for your time. Thank you very much.
Thank you.
Over to you, Councillor Campbell.
I'm staying with Mark, if that's okay.
Yeah, of course. Yeah, yes, fine. Silk will get on.
I move that the committee note the submission from the ICB as set out at Appendix 1 to the report.
Is that seconded? Is that agreed, members? Agreed. Thank you very much. Thank you, Adam. Thank you, sir. We'll now go to item 6. Over to you, Mark. You know I didn't say that word because I don't like saying it. I was going to say the limb service, but I will say the first part. Over to you, Mark.
Thank you very much for inviting me back. Hopefully you've all had a chance to read the paper. I'll keep it fairly brief and just highlight what I think are the key points. So we've confirmed previously that Streeper will be the provider of prosthetic services for Kent and Medway in the southeast London. They're currently working to sign the lease on the property on the Lower Boxley Road. There has been a delay. It's been incredibly difficult to find the right real estate for that service, and that's because you need to have the clinical areas, the consultation rooms, the gym, the workshops, and I also appreciate the last time I was at Haskell, you offered help and support in finding the location. Streeper start to deliver the services from December, so a week away. In the current location, and the plan is the renovation of the new facility, new estates will start in January and run probably through until till spring, and then the service will transition to that new estate. I've also included in Appendix 2 just a brief outline of some of the work that Streeper do, because I don't think they had an opportunity to really showcase their work, and I'm sure they'll be keen to come back in the spring or summer to highlight the changes and the benefits of that service. Just important also to note that the 20 staff have been engaged and are expecting to TUPE over to Streeper in a week's time. Positive feedback from the staff around the new facility and new estate. Again, just reiterating, so the current service covers 101 roughly patients. 20% of those are Medway, the rest Kent, and a small proportion from southeast London. We're moving the service from one location to another. There's no other changes that we're planning. The staff remain, the patients remain, and I think some of the benefits you'll see are the improved access to those services. I made a commitment previously that we would attempt to find somewhere that was within a 10-mile radius. We've done that, so I feel that we have done what we said we would hope to do. So I hope you can see that this is a positive outcome for all of the patients in Medway who use the service.
Thank you, Mark. Councillor Wiley.
Thank you. It wasn't on my list of questions, but by what you've just said, if all the personnel are TUPEing over, but the building's not ready, will work continue in where they're working at present until...
Yes.
No, that's fine. Assuming the building's fit for purpose, which if it's being fitted it will be, Maidstone does seem a good alternative and central position for Kent and Medway, but not so much those in London or southeast London. Is that because where they are now, you can come to Chatham Chatham Station, and it's quite reasonable to get to the hospital, etc. Not quite so much Maidstone. Is that going to be a problem for that? I know it's not our area, but will it be a problem for those people?
I don't believe so. I think that it's got good motorway links, and then also there is the train station just down Lower Boxley Road. So I think it's a good compromise. As I said, it was difficult to find the right estate, and I think Streeper. That's hence why it's taken so long to get to this space. So there's always likely to be some compromises, but I think actually. If you look at the location and you look at the building and the potential of the building, I think we've made the right choice.
Right. And on that, the survey didn't seem to clearly say, would the people using the service, would they like the change? Are they happy where it's going, or whether they would like somewhere else? There didn't see much detail of the survey results. But can I add 25% of people responding is a very high rate for most surveys?
I had also noticed that 25 or 26% is a good return. So good patient engagement and responses back. The conversations that Steeper have had with the staff have been positive as well, and I think they would welcome, a purpose-built facility. No disrespect to the current location, but the opportunity to have a building which is tailored by some of the positive reviews from patients, but more importantly from some of the benefits the staff would see from a change to the facility is welcome. So I think the staff are looking forward to that move.
Yes, but I would have liked to have seen more of what happened within the survey and the responses you received. But
if you want that, I can probably go and find that if I speak to Vicky at Streeper.
Yep, if you could send that to Terry, and if Terry could pass it on. And just the last comment really is, I do think this is a substantial variation in the technical term, but in my view, there's no purpose in declaring it as such. So I'll be voting that it isn't if it goes to a vote, if that makes sense. But thank you. Thank you.
Thank you very much, Councillor Wiley. I've got no other members. You'll be pleased to know, I think I wouldn't be recommending for members to vote it as an SV. You'll be quite shocked me saying that, won't you, Mark? I think, no, it's really good with Adam next year is just to say all of your colleagues, Adam, even though we've had issues, we get on with all of your colleagues. They're all professional. The reason I'm not recommending an SV is because everything Mark promised he would do, he has carried that out and done and communicated with us all the way through. And I think that's this was a really special service that we wanted to keep in Kent or Medway. That's what we said at the very beginning. And we've achieved that with, I think, a really good company. Obviously, if there was any issues, you can bring that back to us, but I certainly wouldn't be recommending two members to do an SV either, Councillor Wiley. So, Mark, you'll be pleased to know, I'm sure, that. So I'm going over to Councillor Campbell.
Sorry, I'm going to be cheeky, just a quick remark because I didn't put my hand up earlier, so sorry. I just want to say it's really positive that you got a brand new facility where you're going to move the service to, and it's going to be fitted up to need. Because I think every time I use NHS services, I just think wonderful people working really hard in buildings with equipment that just aren't up to the requirements. So that's really positive. Okay, now to my official part. I move that the committee notes the update on the reprocurement and mobilization of the prosthetic limb service and the substantial variation assessment attached at Appendix 1 to the report, that the committee determines that these proposals do not constitute a substantial variation or development in the provision of health services in Medway, because this committee has been kept informed at every stage of the process of reprocurement. The service is going to be maintained and the staff are also going to be maintained in the new facility.
Is that seconded? Seconded? Is that agreed, members? Agreed. Thank you very much, Mark. Thank you. We won't make a habit of it, but thank you very much. Thank you. Thank you, Adam. Thanks for your time. Can I ask KMMH just to come forward? I am going to just do a 2-minute break, but come forward anyway. I'm just going to close just for 2 minutes. The reason I'm closing is because it's got really cold in here, I know. And it's Okay, welcome back, members. We're ready for item 7, Chatham Medway Mental Health NHS Trust. I want to say KMMH. You can correct me, Adrian, I'm sure. But over to you. Over to you, Adrian.
Thank you, Chair. Good evening, everyone. Thank you for giving us the opportunity to come and update you on our CQC response. First of all, I'd like to say that we fully accept the CQC findings in full, and that we have set out an honest overview of the findings in the paper, and how we intend to make meaningful improvements on that. It's fair to say the reports were not easy reads for us, but they did not contain any surprises. Many of those areas that had already been identified in the CQC reports, we were aware of, and in fact we've discussed some of them in the last couple of years as well. And we have been working on them, and a lot of those areas that were highlighted we were already working on, or we were planning on addressing in the third year of this 3-year strategy as well. Where concerns were raised on safety, we took immediate actions, and we have developed a transparent improvement plan with the 4 themes that are set out in the paper tonight, all with exec oversight as well. We're confident that with the support and dedication of our staff, who are committed to deliver these improvements, we will make quick progress on this, and we're more than happy to keep Scrutiny Committee updated with those plans and that progress as we go forward over the coming months.
Thank you, Adrian. And Donna, members may not have met you, so I don't know if you want to just reintroduce yourself here. And some members here may not have met you already.
Hello, everyone. I'm Donna. I'm the Chief Operating Officer and Deputy Chief Executive for the Mental Health Trust.
Thank you, Donna. Members. Councillor Wardie.
Good evening. I was going to ask about the 2.1 safe being your inadequate, you know, the worst of all of your judgments. And you said you came up with immediate actions, but you also said you were aware of these problems already. So why weren't the immediate actions you put in place, you know, already underway when you first were aware that, you know, there was problems? Please.
Sure. So those actions that we put into place immediately were on very short-term findings from the CQC. In terms of the general themes that the CQC reports have pointed out in terms of our community mental health programs and our community mental health services around the model and around the waiting times, we'd been working over the past 18 months to address them and put into action a new model, a refreshed model, and addressing some of those areas. Where there were incidents, for example, in terms of health and safety or mandatory training that were identified, we've put in steps to either rectify them immediately, to ensure that there's now processes in place so that we have a standard check on them going forward, and where necessary, the necessary policies have been updated to reflect what is needed of them.
Thank you, but that doesn't seem very satisfactory. You were aware of them, you'd put in some remedial action beforehand, but obviously not enough, and it was still inadequate. So before you'd done anything, how poor were they? They must have been worse than inadequate, and, you know, for a judgment on safety, that's pretty poor.
So a number of those safety issues were around particular clinical areas where the inspections have found some areas of concern. The other area was around the development of our new risk assessment in terms of how we identify the risk of those individual patients and address that. Do you want to comment on that? Now, we had been introducing a new way of a new process of risk assessment, which is a much more holistic approach to risk assessment and to care planning. I'm going to hand over to Donna, who will be able to give you a bit more update in terms of that.
Thanks, Adrian. So just to set the context a little bit, the the inspection took place when we were in the middle of doing a significant transformation.
Sorry, Donna. Councillor Wiley, turn your mic off,
Sorry.
please.
And the reason we were undertaking that transformation, whilst it was a national programme for community mental health services, actually we knew we had areas that we wanted to address within our community services. We hear from our patients and our carers and their families around particularly access, for example, very historically very hard to get into what are secondary care mental health services, and very hard to get out of those services once you are in those services. So we had areas that we wanted to address. We were also aware that our risk planning wasn't as robust as we would want it to be with our patients, along with, if you will, quite an old-fashioned way of thinking about care plans. So these were all crucial for us to address during the transformation. During that process, what we hadn't accounted for was the large volumes of patients that would come through our doors that perhaps didn't need a service from people like ourselves, and we'd completely underestimated the way in which we spoke about a new service and, if you will, a single point of access. That's the first thing. And secondly, we didn't quite get our planning right around how many people would want a lower level intervention, a medium type intervention, and a high level intervention from people like ourselves. So when the inspection took place, one of the areas that they identified was that we had very long waiting lists, and these were one of the immediate actions was around, were we confident that the people waiting for us to respond, were they at risk? And had we adequately assessed their needs at that point in time? And given the volumes that we had, we couldn't assure ourselves that we had taken all the necessary steps that we needed to make sure that we were keeping patients safe whilst they were waiting for us to respond. And that's the immediate action that we took. We started to implement ways in which we could assess better the risks of people that were waiting for us to respond.
Councillor Wiley?
Sorry, it seems a repeat of what's come to this committee numerous times over the past years, and if you haven't by experience gained what's going to happen and can't manage the service even as well as you say you would like to, it gives me real concerns for 10.1, the eating disorders contract, which you haven't got the experience, you haven't got the, well, let's stick with the experience. Yeah, so you've had poor CQC, to put it mildly, for a service that you're supposed to be up and running. You say you're aware of the problems. I'm trying to be polite here, but your failings are obvious and you seem to have admitted them in what you've just said. And now you've been given a new contract for children, which I'm not confident going forward that you're capable of handling. How can you somehow convince me that you are? And before that, if I can say, in the past we've had mental health come to this committee at every committee. You've just said that we're not particularly busy after January, so can I make a recommendation that we ask for that to be put in place again? Yeah, thank you. And sorry, can you explain how we can be confident going forward, A, that the adult service will improve and stay improved this time, and on the children's services that you're just taking over?
Thank you, Councillor Waddy.
Sorry, can they answer some?
Yeah.
In terms of the improvements we've made to date following the inspection, when the CQC inspected the Medway services, we had around 466 patients who are waiting over 90 days to be seen in February. That number is now down to 199. We've put in place processes to check on those patients who have been waiting a long period of time, contacting those people regularly to ensure that they are as well as they can be, and that any interventions necessary they're signposted to. The average wait for patients in Medway is currently at 52.3 days, which is one of the lower ones within Kent and Medway. And the average wait for what Donna was talking about in terms of the new risk assessment and care planning process is around 21 days for Medway. So those numbers have improved since the CQC arrived, and we implemented the refresh of the community model. With regards to the transfer of children and young persons and all-age eating disorders, the transfer is a lift and shift. So the services with the leaders that are associated with those individual services will also be coming over with the services as well. So that skill set, when we discussed it back in August, that skill set will be transferring over to the trust as well. We are more than happy to come back to keep you abreast of the developments and the improvements that we've made and where we are with the plan, both in committee and outside of committee as well. I'll ask Donna if she wants to add anything in terms of the transfer of care, because she's the SRO for that.
Thank you, Adrian. I think you've covered it really. The main thing is that there is not a change in the staffing of those services for both the all-age eating disorder services and the children and young people's services, and that's crucial. We've been very clear when we're working with the current provider, the transfer in terms of those skills to make sure that we're clear how they're managing those services now, to ensure that that's entirely how we will do that going forward, and we're committed to not making any change during that process.
May I come back?
Councillor Waddy, if you come back in a moment, I'll just let Councillor Perfect come in, then you can come back in a moment.
Yeah, thank you, Chair. Yeah, I mean, I've got a number of observations. I mean, just to come in on a number of points. I mean, firstly, you had this inspection back in March, which obviously, so you've had some time to work through this and work on a response, because I assume, knowing how the CQC works, you would have known about this a number of months ago. This isn't new, and obviously your board of directors would have known at the same time before this was put into the public domain. So, I'm just questioning, and this isn't necessarily the two of you. It's a shame that you're outgoing chairman, because I understand that the chairman is shortly going to be leaving the organisation, which isn't covered in the report either. I understand you've gone out for advert for that, so perhaps you could confirm what's going on in terms of your governance arrangements. Your chairman isn't here, but your board of directors has decided to, at the time when you've received a report here, which is pretty damning. I mean, I've read both online and some of the stuff in the CQC. It's talking about rundown buildings, talking about failure to follow the Mental Health Act. All of the issues that are covered within here, and I could read them all out again, which I think Councillor Wilde is very accurately putting, and not really receiving answers for. So you receive all of this back early part of the year. Your board then decide that it's a good time to spend £250,000 of public money rebranding the organisation, which appears to be a key strategic priority for what reason I don't quite understand. And then at the same time, you're also bidding for more services to take in an organisation that is not able to deliver what it's currently delivering. And I appreciate what you're saying, Deputy Chief Executive, in terms of, obviously, you're bringing over existing staff from these services, but I'm not really concerned about the staff. I'm concerned about the leadership, We've got a chairman who's apparently departing. It's not covered in here about any of the governance arrangements or what your board are doing to oversee any of this. We're then taking on new services at the same time, of which, as Councillor Wildey's just very well pointed out, you have no experience in running whatsoever in terms of the children's services, which this committee raised back with you, Adrian, a number of months ago, our significant concerns about that. And then at the same time, you're telling me that it's, you know, we just had a line that you knew about some of these failings before they came in. Well, I don't know of any other part of the public sector, I'm thinking other parts even within some of our people's services, you know, when a failing school, for example, might be taken over by another academy trust. I don't know any arrangement where a failing organisation that knows that it's got all of these issues is then trying to bid to take on more services. And I'm not reassured in terms of how any of this is sort of working together. And as I say, at the same time, we appear to have a new chairman possibly coming in. We've got terrible negative headlines, both about this, but also about your decision to spend £250,000 rebranding the organisation. And I'm just a bit concerned that it doesn't appear, obviously I appreciate your non-executives aren't here, but I'm just interested in terms of the leadership, I guess the point I'm coming to, of the organisation, in terms of how are the board reacting to any of this? How are the board reviewing, and the executive management team, reviewing the implications of this in terms of how this might impact on your ability to lead those services that are transferring over. And then just finally, in terms of what the sort of corporate direction is around all of this, because you've got all these issues that are laid out here that the CQC are really concerned about, telling you you've got to do all of this, and at the same time you're then trying to bring in more services into the organisation, and doing that with the existing capacity. So I'm just interested in terms of what additional capacity you're bringing in, how you're sort of seeing all this working, really, because I'm just not really... I understand how you're reacting immediately to the CQC report, but that's not really the problem for me. It's more, this is expressing failings about the organisation, and I'm not receiving it. I'm not feeling satisfied that our residents, who are people that are mainly accessing these services, extremely vulnerable, you know, following the Mental Health Act, some of the terrible things that are contained within that report. What exactly is going on from a corporate priority perspective in order to react to that? And as I say, it appears to me the corporate reaction is let's go and get a whole load more services and let's worry about rebranding the organisation rather than focusing on delivery and getting this right. I'm not trying to be obtuse, but I think actually residents probably, and if you look at some of the media stories you've had published, some of the comments underneath that, that appears to be what residents' views are. Thank you.
Thank you, Councillor Perfect. Who's taking that?
I'll start and then Adrian will come in. So just to be clear, with the adult services, as I say, we were already well underway with a transformation, addressing the issues that were known to us as an organisation. And in fact, we'd undertaken an independent review to ensure that those issues were brought to the forefront, and those recommendations were discussed with our board, and we had a very clear programme to address long waits, care planning, risk assessment as identified in the CQC report. So that work was well underway, and just to answer the resource piece, that programme of change has been resourced independently of the other work that's underway, because we recognise that we've got a lot to do as an organisation. We have, and we've always been very, very clear with you around that in terms of the areas that we've been concerned about and that we want to make changes to. So we're confident that as we bring those services in, again, we have resourced that well to make sure that we do that well, and we do that in partnership over a period of time with the current provider. In regards to the chair leaving, yes, she is at the end of the amount of time in which she can continue as our chair, and that's why that's gone out to advert, and apologies that that's not covered in the paper. And you raised another point. Let me just. In regards to you asked a direct question about Mental Health Act, and you're referring there to our health-based places of safety, and that was addressed when that came to our attention. that we were detaining people too long in that suite. We addressed that within a week of the CQC actually undertaking their inspection. Did you?
Thank you very much for that. I mean, I appreciate all of the comments made. I mean, I just have concerns about the implementation of, because this is, you know, is failing, you know, requires improvement, inadequate, requires improvement, requires improvement, requires improvement, requires improvement. And on the other side, RI, good, RI. So it's not, and my concern is about leadership capacity around all of this, because irrespective of whether or not you're bringing in people or not, in any organisation I've worked in, if the business is failing and struggling and, you know, is unable to deliver its current service, bringing in more services at the same time, I just, from a strategic perspective, really concerns me, because the concern for me is you bring that service in, we're trying to at the same time transform an existing service, which you're acknowledging has got significant challenges, at the same time as then integrating a new service into the organisation. You know, with the one chief executive, with you as the deputy chief executive and your executive team and the same board at the same time, and then inducting a new chairman, as you just told us, I just think I would be interested, and perhaps this could be reflected in the update you bring to the committee, about how that's fitting into your strategic plan, because that, to me, from any other public sector organisation, I don't think that would be allowed to happen personally. I mean, I've never seen that. But in the NHS, it always appears to be this is what we like to do. We like to merge services at the same time as the service isn't delivering. And at the end of the day, this is not good enough. I'm fed up with turning up to meetings across all sorts of things where we're just told that, well, it requires improvement and inadequate, and, oh, well, it's not good enough. It should be good. The baseline should be good. The CQC are very clear on that. So I would appreciate you taking that back to your chief executive and the board, about the importance of you being, and this committee having confidence that your organisation is able to deliver this. And I would just also really caution about the importance of public perception around some of these services. And the rebrand was a terrible idea at the same time as you had all of this going on. And I think the board need to reflect that. Thank you.
Thank you, Councillor Murphy. I'll pick up some of your bits when it comes to me as well, so that's okay. If it's anything new you're going to add on to it, Donna,
Sorry, I'm struggling with my button. Yeah, just a couple of things. Just to be very, very clear that the board, this is their number one focus. They are very, very focused on this quality plan in relation to that inspection. So just to be really clear about that. I will just mention the rebranding. So the reason that was undertaken was actually because of the feedback that we've received from our patients and wider stakeholders that KMPT was meaningless in terms of what that means to them. So this wasn't just a rebranding for the sake of it. It was on the back of feedback that we'd had from stakeholders, and in particular our patients that access our services.
I'm going to keep it low. I've got to keep it minimal now because we are time, and I'm very aware, members, that your system's going to close off at a certain time this evening, so we have to be careful on that. Leanne, I'm going to bring you in for, I will, Councillor Lang, before Councillor Whiteley. Just give me a moment.
Thanks for the paper. I've heard the term quick fix. And the thing I wanted to ask you about was the phasing, because it's very, very difficult to fix the plane while you're flying it, and that's what I see is going on here. That time scale, that phasing seems too quick for me. I think this is a longer term, a slower burn than this, albeit I think what members are talking about is the leadership. It's not only dealing with this inadequate inspection, because it's not good for the residents of Medway, but have you given any thought to stabilising in the future? Because if you don't get it right now, you're just going to go round and round. And that was my only concern, really, in addition to what Councillor Perfect said about leadership, is that phasing. yeah, I have concerns about that phasing because it's not a quick fix.
So yes, we are constantly monitoring that phasing, and that phase, we've deliberately put it into phases because we need to make sure that we put those immediate actions into place firstly, and then we move on to address some of those wider areas. I think it's important to explain that a lot of those findings happened as we were already during a process of transformation. That's the first piece of transformation that community mental health services have undergone for 35 years. And so there was that huge piece in terms of that. We have learnt a lot as an organisation in terms of how when you deliver that transformation, you do need that period of stabilisation, then optimisation, before you then start to refine. We are regularly monitoring that plan 3-4 times a week. Just this afternoon, I met with our chief information officer and a number of other senior leaders within the organisation to see where they are in terms of their parts of the plan that I oversee as well, and how do we need to adjust that. Now, yes, I think the phase 1 and the phase 2 is doable, but I think particularly some of those areas around the culture and around embedding and around that improving thing will be ongoing, and I suspect that will be reflected in future work that we're going to be doing as well, because you're not going to solve that overnight because it's a 35-year transformation that's happened.
Thank you, Leanne. Councillor Jackson, just your questions, please.
It's just a really quick clarification. I just want to understand what Donna said. This is why I want to do it, because I want to make sure I get it right. You said that you had so many people in the system waiting to be assessed that you couldn't triage the risk. So we had people waiting and you weren't triaging them to see what risk they were at.
Thank you. Yeah, happy to respond to that. No, they were triaged. People were triaged, and their risk was triaged immediately. And in fact, whereas historically we may well have had waiting lists or an 18-week waiting for people to enter treatment, we were actually seeing people within 4 weeks in terms of assessing them well, making sure that some people were actually entering treatment. The problem came when we had some people that were waiting for lower level interventions, so their risk was considered to be very low, but they were waiting far too long to get into treatment. So anybody that was deemed at risk at the point of being seen was seen very quickly. But we had large numbers of people waiting for a lower level intervention that actually were waiting far too long. And that's what the CQC identified.
Okay, thanks for that clarification.
Thank you, Councillor Jassing. A good intervention there. Councillor Shocker, you got a question?
Yeah, just really quickly, regarding the reassurances that we can have in terms of the improvements that are going to be made, that are co-produced with those that are affected, are you able to share the engagement outcomes of the committee from those? Is that something you're going to be doing anyway, or is it? Yeah.
So in terms of the transformation, the model was co-produced originally with our service users, lived experience, and our voluntary sector partners. That model has been refined, and again, we've done that in relation to our partners who deliver those services with us, and indeed people who are using our services. So yeah, we can certainly share some of the findings with you if that would be helpful. And just to be clear, that one of the things that we're doing that's very, very different is we're using something called Dialogue Plus, which is a new assessment tool. It's a co-produced assessment tool with our patients, and we can certainly share the findings in terms of when people come to us, they're telling us much more broadly about what would help them in the future, and we can certainly share the analysis that we have of that.
Thank you, Councillor Shocker. Councillor Nain?
Thank you very much. With most of the patients, like you said, being at risk, and with the CQC talking about safety. And you've also stated that you're going to improvement will be in phases. So do you have any idea when do you think most of the patients who are on the, at risk and are still on the waiting list, do you have any deadlines or any time spanning that you can say, okay, within this time, we're going to make sure that this normal, this patient's normal is going to be reduced to maybe some percentage out of what we have at this moment? Then, would you be, how would we be informed about where you are? Let's take maybe, okay, we've reduced the number to maybe less than this 20, less than that. Do you have any time scale to, within that, what you'll be working with, within, to make it more safer for people who are at risk? Thank you.
Yeah, so just to be very, very clear, people who are presenting at risk in our new model are seen within 4 hours. So if somebody is in a crisis and at risk, we are committed to seeing them within 4 hours in our new model of care, and we do that. The issue is the people who are not presenting at risk and were in a lower level need, and that's where people were waiting longer. So those at risk today would be seen within 4 hours of that risk being highlighted.
Thank you, Councillor Nain. Just briefly, Councillor Wiley.
Right, very briefly. You just said that your focus was on sorting out the CQC, etc. That was your #1 priority. I think they were the words. Well, you've just taken on a contract for children and young people and all-age eating disorders. That should be your focus because that's a new service. And you said you're using the same skill set and the same staff from a service that already had problems. So that also causes me concern that your management's got problems, to put it mildly. That service had problems, and you're merging the two together. It just does not look good for the future. Was that brief enough?
Perfect.
Thank you.
Councillor Wiley. Did you want to come back on?
Yeah, so can I just clarify? The people that are coming across from the children and young persons and all-age eating disorders, they are coming across, and they are the leaders that are already currently providing that service within North East London Foundation Trust. They're not currently part of KMMH. They will be coming across with regards to that. And with regards to the resource to bring that over, we have additional resource to help support that transfer over.
No, you can pick it up. Go on, Councillor.
Right. But the present service for our young people is not fulfilling what we would wish. They are also failing in their own way, and you're using the same people to carry out the same job. That's the point I'm making.
Okay.
I think the point Councillor Wilde is making is that we've got as I made the point earlier, you've got the same chief executive. Your chief executive will be running the new organisation with these services that are going to come over. And I think Councillor Wilde hit the nail on the head with the problem with all of this. And I think you Deputy Chief Executive, just made that point, which is your top priority at the moment is apparently reacting to the CQC report. At the same time, you're saying, well, we're going to also bring in this service over here on the side, and we're going to bolt the two together at the same time. So we're trying to mend Service A, bring in Service B. It's a bit like a bankrupt company trying to, at the same time, carry out a merger of another organisation. And another organisation that's got its concerns. And I think that's the point, and I think the Chair will probably make that point, that you need to be making to your board, because it's not good enough. I mean, the chairman of your board should be here fronting all this up. And I think I'm going to let the Chair. Thank you, Chair.
Thank you very much. Thank you, members. Adrian, you've been here many times, okay? I mean, to be honest, and, Donna, you're very welcome as well. You're always welcome here, but the members are all right. It should be your CEO here tonight and someone from your board as well here. It is just not good enough making you two come here to try and defend this. Because I've no doubt that your service does help people. Of course it does. We know it does help people, and we know mental health is a tough service to deal with, and you do, I want to say there are parts of the service you do which are great, but you can't ignore this CQC. And it's not the first CQC, it's not the first time we've been here talking about, when I look at the points on here which says, first thing you're going to do, you're going to get a team, and you're going to look at the phasing, you're going to get a senior leadership team. I've seen all that before so many times here, and it's just not good enough. Surely I've asked your team, you've come here, Adrian, we make you come here all the time, and don't forget, I want to make it really clear, this service, you can hear from members tonight, we are really concerned about this all-age service coming over to you. Really concerned, okay? And I don't want to take away the fact that, the members are right, £250,000 on a name change. It doesn't matter whether you're KMPT or KMHH, whatever you are, our public are going to look at this and say, you're poor service. Because that's all they're interested in, not interested in your name. They're interested in what they're going to get when they walk through your door. And from looking at this report and from reading it online, like Councillor Perfect said, there's real big failures here. You can't deny it. You can't just get a team of executives to go on there and let's do that over year one and over year two. Where is your sustainability plan for a large organisation like yourself? You've got the commissioning service, the ICB, that are saying, yep, it's fine, let's lift this. We won't even go through a full procurement programme, which they didn't go through a procurement service. They lifted and shifted this contract to you. And then we've got here, around this panel, a CQC report dealing with vulnerable people, and a lot of this is down to you guys. It's down to like from the top right down. And every time, Adrian, you have to come here and put up with this and us having a go at you, it's your leadership that are failing here. And for your commissioners and your funders, someone should be opening the door and saying, what the hell is going on here? Where is your chief exec this evening, Donna? Where is she this evening? Is she reporting somewhere else? Is she coming along and saying, I'm terribly sorry, members, for this? Where is she? Because it's not the first time I've asked where your chief exec is. We've never met your chief exec. Your new chief exec. We never met your old one. We never met your new one either. It's a total discount of what we do here on Scrutiny. And it's a total abuse of our residents. That's what it is. And do you know what? You two are having to take the blame. You two are in front of us getting this from us. And actually, because you're here, rightly so, actually. And Adrian, you come along on this journey with us so well. You know that, because I'm going to tell you now, I want your chief exec here in January. And I want someone from your board here in January. Don't forget, we've got an SV on your all-age services. And I'm going to try and ask as much advice as I can to find out what we can do, because the members here this evening, from what the feeling I'm getting is, they don't feel that service is safe with you. And we had even our own departments with some concerns around that service delivery coming over to you. You reassured us, Adrian, at the time. We had all these concerns, but still it was just done. You and the ICB colleagues sat here, it said it's fine, you've all got faith in each other, that's wonderful. Then all of a sudden this pops out. We didn't know about this till all of a sudden we get the news headlines on this. But you knew when you were sitting there a few months ago that you had these internal issues yourself. And the ICB must have known that you had these internal CQC inspections going on, because the inspection was in March. You would have had some feedback, and you have to go backwards and forwards. I'm sure you'll hear that from the hospital when we speak to them. But actually, it is an abuse of this committee. An absolute abuse. £250,000, let's spend that on a name change. Let's keep talking about we're going to reform, we're going to reorganise. Them words we heard earlier, and we had faith in the ICB saying it. Every time I read it in your organisation's write-ups here, I don't believe any of it. Because it isn't, for over 2 or 3 years, nothing's changed. And I feel for you, but I tell you what, our residents deserve better. They deserve better from what they're getting from your organisation. And your staff deserve better. Because remember, we've had all the other issues with the culture. You've had all that yourself in the past, cultural issues. Let's not think it's just the ICB and the hospital and others that have had these issues. You've had horrendous issues with cultural, with bullying, with other stuff with your staff. And here they are again, your staff that are on the front line doing some great work are reading this and seeing that, oh, don't worry, we're the board and everyone, we'll get on top of it. Maybe it's a good job that your chair's moving on. Maybe it's a good job. Because if I was chairing your organisation, I'd be thinking, what the hell's going on here? Shall I spend a name change here, or shall I get on with this CQC? What's best for my resident? That's what I'd be saying. I wouldn't be saying, let's just have a look about how we rebrand. I understand why you did it, right? But this is not good enough. And this panel is not going to accept it. And like I say, I'm going to find out as much advice as I can to find out what we can do about that shift over of that service to you. I'm going to ask whoever I can. I'm going to write to the ICB. I'm going to find out what we can do. Because you're not reassuring me, and you're not reassuring the members around this table that you're capable of reorganising your whole organisation, which is, you know, where is your reorganisation? I don't know. Reorganise your whole, deal with this CQC and worry about how you're looking on tops of headed paper. And also, let's take on this massive contract. You're not at that point of being able to do it. And I have no faith in you delivering it. And that's a real shame, isn't it? Because, Adrian, the last conversation we had, we were thinking we were on a good trajectory, we're doing well, everything's great. And it's not. And you two have been put out to take the flak. And it's appalling. I hope you take that back to your chief exec. Because I'm going to make sure we get that invite over to him. And let's see if she turns up. If not, I will have an empty chair sitting there with her name on it. But KMPT, I'm going to call you that. You're going to be coming back here, whether you have to bring all your teams or not. But I apologise to you two because you shouldn't be fronting it up. And you know, that disappointment's clear. Vice Chair.
So, sorry, Chair. So we're saying in January they have to be back?
I want a member of the board and the CEO here.
Okay, and what about Councillor Wiley's request
Well,
that they have to come
it's
back
going to be
every
one
month?
of many. Unfortunately, Adrian's done it before, Vice Chair.
Okay.
Adrian's had to come back every time we've called them back. And we can, under an SV, we can keep calling them back. But can we also say, I think Terry's picked it up, we're going to try and I'll speak to Leanne and others and write to the ICB about the transfer, lift and shift of the contract.
Chairman,
Yeah,
can
Councillor
that
Wiley?
recommendation be a cross-party? Yeah,
We
but
always
to
do
make
that.
point,
I think you're always assured we always do that.
Yeah.
So, yeah. Thank you.
Okay, I move that the committee notes the update from KMMH as set out at Appendix 1 to the report. I further move that a member of the board and or chief executive of KMMH return to this committee at the January meeting. Their attendance is likely to recur over the coming months. The committee is also going to explore writing to the ICB as a cross-party effort to raise concerns about the lift and shift transfer of services to KMMH.
Is that seconded, members? Agreed? Agreed. Adrian and Donna, please take back. You've got some amazing staff, and they deserve better from the management team. Because your staff are on that front line dealing with hell and dealing with some real tough issues. And all they see is all the backroom stuff that's just not working. And I feel that I really feel for your staff team. Thank you very much. Thank you, Donna. Thank you, Adrian. Can I have CCAM, please, coming up? Don't look too worried, CCAM. It's okay. You'll be all right. Hi, you guys. Can you just introduce yourselves just for the benefit of some members that don't?
Good evening, councillors. Chair Matt Webb, Deputy Chief Strategy Officer for South East Coast Ambulance Service.
You've still got Adam Doyle on yours, I think, but you're with CCAM now, Adam. That's okay. But thank you. Okay.
Strategic part. Let's try again. We have green light, thank you. Daryl Devlier, Strategic Partnerships Manager for Kent and Medway for South East Coast Ambulance Service.
Thank you very much. Who's introducing? I mean, obviously taking it as read because the members have read your report, and I just want members to be aware there's only a certain amount of things that you'll be able to tell us tonight because there is an ongoing review, but that doesn't stop members asking questions and maybe getting feedback at a later date from you. Councillor.
Thank you, Chair, and always good to meet more Deputy Heads of Service. I was just in thank you for the report, and obviously that those conditions that there are ongoing investigations. It was interesting in October. There was a public service documentary using covert filming into the operations of a blue light service in South East England. It was interesting to see the organisation's approach, taking accountability of the issues, committing to resolving long-standing cultural issues, and to make sure that the members of the public are treated with dignity. Now, that's enough about the Metropolitan Police Service. I was interested to read your response, and to be frank, it's defensive. It's not necessarily understanding the importance of public interest. It's not looking at the issues that are being raised, that people legitimately have, instead seeking to disparage public service journalism and whistleblowing. I'm just wondering, is this a symptom of a defensive culture that is seeking to avoid blame rather than trying to deal with the issues out there?
Thank you, Councillor. I'll respond to that. I'm sorry that it came across to you that it was a defensive answer, and it was not intended in that way at all whatsoever. And the reason that our response to the documentary is written as such is because we are mid-investigation at the moment. So the investigation into the incident is one of the most deep, complex, wide and sensitive investigations we've ever carried out, with quite a number of legal implications behind that. So it's highly sensitive in nature, and because we're mid-investigation, we just don't have the ability, and it's not appropriate, to answer certain questions and make some comments until that investigation process has concluded. So we are very happy as a trust to answer any questions put to us in detail at the conclusion of the investigation. But at this moment in time, it's just not appropriate for us to comment on some of the specifics.
I mean, I mean, it's not necessarily the first time that the response to public interest journalism. So, for instance, Sky News' reports to some of the individual cultures in your organisation also elicited a similar type of response. Now, admittedly, in that response, obviously, that there wasn't some of the sensitivities as you described there. But it does seem that this is happening quite often, and it's happened over a long period. Now, I'm a substitute tonight, so I haven't necessarily been in discussion with you, and I don't have the relationship. But is there something that needs to be done about SE cams and making sure that your culture is looking to improvement and to public improvement rather than necessarily having to, defend all the time? Because I'm sorry, there does seem to be a pattern there in your culture.
Thank you for the question, Councillor. I think at the moment that's an assumption. I think we need to wait for the investigation to conclude. This was part of a national programme, so whilst the footage, admittedly, appears to have been from our Medway contact centre, we need the investigation to understand where there are breaches from a data protection perspective when we consider patients. any aspects around staff wellbeing, and then to address the concerns that have been expressed around public confidence. For the purpose of tonight, Chair, there's limited assurance we can offer. I think the high-level assurance from our perspective, from a CCAM perspective, is there is a comprehensive investigation ongoing. We are working with the Information Commissioner's office. Clearly, we are taking this extremely seriously. I think the thing to clarify is there is no evidence of patient harm currently from the external or internal investigations and reviews that have been undertaken. And we, of course, will be happy to come back at a later point, as Darryl has mentioned, in January or the start of next year to provide further assurances.
Thank you. Thank you, Councillor Field. Councillor Wiley.
Thank you. In the past, there have been reports that have not put your organisation in good lights, going back. But as a patient, my mother-in-law, my family, and I'm going back over a few years, we've all used the ambulance service and we've all found them very good, very professional, often taking too long to arrive, but especially after COVID, but always very professional and always very good. I believe late last year, I and a few other councillors visited and we walked around and we spoke openly with your personnel on doing their job. And they all seemed happy, straightforward, would talk to us, which in the past, that hasn't always been the case. So from personal experience, I've found that your service has looked better from a visit and personal use. So, I'm sorry we are where we are. And when the full report's out and you're happy to answer, I may have more questions, but well, for now, personally, I'd like to thank you for the service, for my personal experience, but that's just me. Thank you.
Thank you, Councillor. I appreciate there wasn't a question there, but you have just made reference to our people within the Medway Contact Centre, and I think just to highlight to the committee, there's clearly been a staff impact from what we're discussing as far as the programme that was broadcast is concerned. It's felt there has been a breach of trust, and we are therefore, I think, just for assurance purposes, offering enhanced emotional support and wellbeing support to colleagues. We've increased the leadership visibility at the particular site, and are maintaining regular communications whilst we continue to investigate, and fully appreciate your concerns there. I know last time we provided a report, we also brought the NHS staff survey findings, of which was the best NHS staff survey result that we've had in CCAM's existence. So again, we'll come back at the start of next year, Chair, if that's okay.
Members, so just from me, before... Oh, sorry, Councillor Perfect.
It's just a brief one. I mean, it just follows on from what Councillor Field was sort of saying. I'm just interested in terms of this, because I can understand what you're talking about in terms of the data protection problems and all of the issues that Channel 4 sending in a person into your organisation and all of that, and how you recruited that person. Yeah, but these things happen. I think, as Councillor Fields referenced, other organisations, I've watched lots of documentaries over the years of people going, and not just in the UK, but all over the place. You know, this is what happens. You know, it's a bit like... These things happen. I'm just interested in terms of this investigation. I assume, as well as all of the data protection concerns, which I know, you're going to have, there's going to be an element around actually what was featured in the documentary, and you're going to then come and talk to us, I would hope, Chair, about what was actually in it. I mean, I haven't watched it all in its entirety, but I heard lots of, you know, it was not only covered locally, but it was covered nationally in terms of a lot of the concerns that were raised, that were real problems, and though, you know, I don't think anyone's disputing the footage was real in terms of what was going on in terms of your contact centre in this, you know, just up the road there. So, I mean, I think when you come back with those findings, I would think it would be very useful to take the committee through, maybe through a presentation, Chair, if you'd be amenable, some of the things that actually happened in that, what's going on, why that happened, what you're sort of doing to address it, because I think that would go some way in terms of reassuring the committee, because I think what I'm just a bit concerned about is there seems to be this sort of inherent focus, and I've noticed in your press statement as well at the time, on the ICO and the data protection element. But I mean, I didn't, from the bits I've seen of the documentary, I wasn't really worried about data protection. I mean, most of it's all fuddled up anyway. I'm just more worried about the service that our residents are receiving, I think. And I think that's what the press and the public will be more interested in than us sort of saying, well, this shouldn't happen because it's data protection. It's like, well, that's obvious. But, yeah, there is public service broadcasting, and as Councillor Fields referenced, it's already happened and that's already out there. So, it's you know, you can learn stuff, but it's unlikely you'll have, you know, the more important thing is what you learn in terms of the service. Thank you, Chairman.
Thank you, Councillor Perfit. Matt, you want to come back on it?
I think just thank you, Councillor, for that. I think just to reiterate, the footage, yes, was the Medway Contact Centre. This was part of a national programme that was looking at the NHS and the ambulance 999 service in its entirety. So, again, I think any premature detail could compromise the investigation that's ongoing. We will happily come back once we've concluded that and we have a clear outcome to present back.
I mean, I think from me, the points are being made here tonight. I know, and Dale, you did tell us there wouldn't be much you'd be able to say, but I feel, you know, there was a lot gone on to concern. It's not about, there's enough with your staff having to put up with that, what happened. There's enough of them having a camera next to them with someone with a camera using a camera, and you've got other operators doing a good job behind them. So I can understand all of that. But there was also staff members there saying things like, when we say that, but the ambulance is never going to turn up. I think them comments are the things that we will be really concerned about. Is there a certain time of the year where you'll be saying that and really they're never going to get an ambulance? Now, I know your guys are amazing on the ground. Everyone here would agree with that. They are. But again, I'm going to say, you know, obviously I suppose your staff are expecting a response from the management with regards to how that ever happened and how did that carry on. The other part, though, members, that we are here and is about the group model. Now, again, we weren't told about the group model. We saw it on the press. And usually the HAS would be told, you know, that Darryl, and anything like that, any changes, Matt, we should have been told that you was merging and going in, not merging actually, but merging with yeah, let's use the word merger. I'll be careful on that on my next time, but let's use the word merger. But we weren't told that. So that's a slight disappointment that we weren't told that was happening. Can you reassure us? Would you like to talk to us about that and about the organisation you're going into to reassure us that your service at the front end is going to be wonderful and so much better?
Yeah, absolutely. Yeah, thank you for letting me respond. I want to start by reassuring the committee that you weren't forgotten about or missed out in any communications. This is really important. So when we last attended in March, we updated the committee that boards of both organisations, that's CCAM and SCAS, South Central Ambulance Service, had agreed to appoint a joint strategy lead to look at opportunities and options, develop a case for change and a roadmap for what we may be able to do moving forward. And when the board was presented with the options and discussed, and they signed off on the group collaboration being the best way forward, you were notified immediately at that point. So when the decision was made that the group model would be the way forward, that's when you saw the press release that we produced and forwarded to you. So the work hasn't started yet. That's important to say. We are not in a group model at the moment. We are still separate organisations in our own entities. And the move to this group collaboration is really well aligned to the 10-year health plan and our strategy, which we've presented to you at the last two HAS meetings. And the focus that we have on local service provision is only going to be enhanced by all of these elements. So we've started a restructure towards what we call a divisional model, which is essentially system-based with our local geographical areas mapping to place-based healthcare. And then when that comes to Medway specifically, we've been slightly hampered in the past with our geographical footprint being combined with Dartford and North Kent. So this will see us separate now from the 1st of April into Medway and Swale specifically and Dartford separately. So that's the own local operations management team and other elements such as an additional team of advanced paramedic practitioners that will be able to focus on that local service provision. So I think it's important that I want to reassure you that not only is looking at this group collaboration not taking away that local focus, but it is very much moving us overall to align with all of the developments nationally and locally. The neighbourhood health programme schemes, the whole left shift community scheme will help us sit more effectively and more efficiently within that.
But without considering local government reorganisation or
Oh, no,
changes that will happen, because there might not just be Medway and Swale, it could be a lot more than that going on.
Absolutely.
Where does that come in this merger?
Well, obviously we are very health-centric focused, as every other health organisation would be. But the local government reorganisation and everything else connected to that is also equally important. And you see that from the top with the NHS direction of the merging of health and social care, which at the moment has been painfully separate, and we're all well aware of issues that it causes us. So absolutely, you're very valuable stakeholders in this, and your input into us producing this collaborative model is most welcome, and absolutely you'll be involved with us developing this going forward.
Thank you, Daryl. Can you just remind members of the timelines so what's happening now with the group model? Where are we at with that?
I'll take that, Chair, if that's okay. So I think just to reiterate and the point, so this is by no means a merger, and just to clarify that point, so a group model is we will continue to operate as two sovereign organisations, even once we've appointed the group chair, the group CEO. Where we're at the moment, the timelines are being finalised, but actually the most significant milestone that we now face is the appointment of that group chair and that group CEO. We're currently progressing that. I would not like to be held to this, but we are confident that we should know where we stand with that group chair and group CEO appointment. I would think just the other side of Christmas and the start of the new year. That will then unlock how far we can move forward and actually what the priorities are. But just to reassure the committee, the two organisations are also discussing actually where we can look at collaborating, prioritising strategic collaboration efforts that benefit the two footprints of both organisations and the communities that we serve. Just to build on if I may, something that Daryl's just mentioned. We've come to this committee previously, and one of the challenges that understandably we've had presented to us is that we were split into an east and west sector. And so often we would present data to you for our east sector, of which this was part of, and you would challenge, well, we don't want to see the data from Polegate or from Hastings and from elsewhere. Actually, we want to see the data for our local communities. Now, as Daryl's mentioned, I think we just, to celebrate and to share that positive news story, the last time we came to see you, we were talking about moving to a divisional model. And actually, we have now started the move to a divisional model. So as Daryl's mentioned, we've got 3 field operations divisions, and clearly the one here being for Kent and Medway. The intention, so we've got an ongoing restructure. The intention is to introduce the new senior team to this particular HASC and other HOSC equivalents at the start of the new financial year. So we will have those colleagues in place. And whilst, yes, we are moving to a group model, and that will help us with the strategic collaboration, sort of some of that regional convergence and sharing of best practice, actually from a CCAM perspective, moving to a divisional model, we will have local heads of service. We're increasing the number of heads of service or heads of operation, so you will have a much closer interface to how the 999 and 111 services are operating within your locality. The last point, if I may, is clearly we often update on the physical ambulance response. So we talk an awful lot to the Category 2 mean response time, which is often used as sort of the indicator for how well an ambulance service is performing. When we've come to the committee previously, we've talked about our shift in the virtual care space. We recognise that far too many patients end up in emergency departments. It's not the right place for them. They deteriorate, they demobilise, and we need to do better from a whole system perspective. So we've started that journey this year on looking at how we can introduce and optimise that virtual care offer for patients. And the reason I mention that is through the design of that virtual care model, we are very much looking forward at the future system configurations. So we're looking at the fact that CCAM will be covering a region that we have the Surrey and Sussex integrated care systems coming together. Likewise, we'll have the Kent and Medway integrated care system. We're also monitoring the changes to local governance structures, boundaries and setups. So just to reassure the committee, that very much is in mind when we're designing that virtual care offer.
But surely you can understand, Matt, I know Darryl Wilkes, he's been here, as you have, you've been here before, you know, you're nearly at the end of it, you're putting it together. So we're getting it now, Darryl, we're getting the press release now, but really it's been going on for some time, this discussion, and well, it has, Matt. You don't just agree a group model in 2 weeks and work out how you're going to go across all the areas, and it's something that you did say in March, I remember, that you were looking at. This is you're now moving to the model of getting your group chair and group CEO in January. So this isn't something that's entirely up to you as an organisation. I'm just trying to remind you that, again, from that consultation point of view, there wasn't any, right? So you may not want our, you may not want our views, but what I'm really worried about is that when you come back here and you and your colleagues and maybe your group chair, whoever, you never know if they're in place, when you come back and you're going to report back on the television programme incident, and then you're going to report back on how this model actually all works, this group model, you're going to, whether it's on a PowerPoint, whether it's a presentation or wherever it is, how do you know that we're not going to say, how the hell did you not think about this? Did you not think about that when you've done it? How is it going to affect our residents? Which you're probably going to get those questions from a really good HAS, we are a good HAS committee here. There's no room for manoeuvre, is there? So when it comes back in January, no room for manoeuvre because it's done, it's a deal done, right? Again, I'm not, Darryl, I'm not going at your frontline workers here. But your senior leadership team have sorted out the deal, it's all done, and when it comes back to us, you're going to show us how wonderful it is, and any comment we make is not going to make any difference whatsoever. Do you understand the little bit of frustration from the panel?
I do. I think just to reiterate, Chair, because I'm conscious that this could be perceived as a fait accompli, a done deal. I think just to reiterate, yes, there have been discussions ongoing, and this follows an independent external regional review that NHSE England commissioned, by the way, to look at how could the ambulance services work better, because we know across the South East there are considerable health inequalities, we have variation in practice, and we need to do better. We are the only region whereby actually we've got the 2 ambulance services operating across that NHSE regional footprint. So just to reiterate, we are in the first part of this. The first milestone is that appointment of a group chair, group CEO. I think the microsite is within the report. I would welcome colleagues to look at the microsite because, and I think this is an important note, service setup is not changing locally, and that's why this isn't a formal consultation. There are strategic benefits to grouping, but actually the key message today is we have moved to a divisional model. We are looking at getting our structures, our people, our service lines closer to communities. So the first strategic milestone is that appointment of that group chair, group CEO. We would then absolutely welcome engagement to then understand, well, how could we take that group model forward to benefit the various communities that we serve. Take the point, I think perhaps we've been more on transmitting, we've communicated out, but to reiterate, there would be plenty of opportunity for engagement and we'd welcome that.
Just to finish, I'm just trying to hand out the olive branch really, because, with SVs and variations, we don't want to be going, you have the possibility of that. And we want to be careful about how, if you're remodelling and it's for the benefit of residents, that's all we want. We want something, including the next time, we want what's best for our residents. But without the communication comes the issues where all of a sudden you'll start getting all those issues where we're going to ask for reports and we're going to ask for backups. And that's all I'm trying to say is that the more communication we have, Darryl as well, I know you do communicate with us as well, more communication we have, the better it will be going forward. Thank you very much. Vice Chair.
I move that the committee notes the report.
Seconded, members? Agreed? Agreed. Thank you so much. Thank you. I know you travel. Thank you, Daryl. Thank you for coming this evening. We look forward to the report in January if you keep us updated on that. Thank you very much. MFT, please, to the front. The final act. Would you like to come forward? Can I just say, Jonathan and John, you know, you've had a very interesting evening, I'm sure, watching us here, and you know, I'd like to apologise for you having to wait because it is pretty cold out there too. So, if we can take the report as read, but if you'd like to add anything to it, that'd be great. And I'm going to ask members because, just reminding members, there is a 10 o'clock turn off on your system there, Terry, isn't it? That's right. Oh, you're all right, David. Okay. The lights are not going to go out in there. I'm just reminded that all your agenda packs will switch off. So, Jonathan or John, would you like to go?
Thank you, Chair. I've got a few things I just wanted to pull out, if that's okay. So, hopefully, you've all had a chance to read the comprehensive report outlining the outcome of the independent review commissioned by the Integrated Care Board and the case for establishing a formal group between Medway and Dartford trusts. The independent review is clear. There are substantial opportunities to improve quality, strengthen services and create real benefits for the 800,000 people that we serve in North Kent and Medway. But the way we are working today will not get us there. Collaboration to date has often been informal, ad hoc and without the governance needed to make change stick. The scale of our challenges, demand, waiting times, workforce, ageing estates, deficits, digital fragmentation, requires a structural response, not an incremental adjustment, a bit like we talked about last time I was here. The preferred option outlined is a group model, a formalised partnership with aligned governance and a shared leadership team, while retaining two sovereign organisations. This is increasingly the direction of travel nationally, and it's fully aligned with the NHS 10-year plan and the ICS ambition of one system, one population and one budget. Both trust boards, our governors, the ICB and NHS England have endorsed this direction of travel, but I want to reassure the committee that there will be no immediate changes to local services. This is about putting the right foundations in place, shared leadership, clear operating arrangements, strengthened local site-based management and a structured programme of organisational development. The aim is simple. We want to improve quality and safety, reduce unwarranted variation, create better career opportunities for our staff, reduce duplication, strengthen our finances, and most importantly, make it easier for patients to get consistent, high-quality care wherever they live. This is not about centralisation or one organisation taking over the other. It's about recognising our interdependence, the shared patient flows, the shared workforce pools, and the shared challenges that no single organisation can solve alone. It's also about ensuring that both Medway, Maritime and Darren Valley have strong, visible, accountable leadership on the ground. That's why the group model separates the roles of the group chief executive and local managing directors. Again, something we discussed in detail last time. I also want to be open with the committee, though, that Medway has had long-standing issues, instability in leadership, cultural challenges, variation in performance, and that has held back progress. But we're working hard to address these, but doing so alone while neighbouring trusts face similar pressures does not provide the resilience or sustained improvement that our population deserves. The group approach is about putting in place the structure, leadership and shared governance that will support the improvement journey for the long term. It enables us to standardise pathways, strengthen clinical governance, create shared improvement methods and gain the benefits of scale in areas like digital, procurement and workforce development. We're at the very start of this journey and we won't rush it. We will proceed in phases in the open with continued engagement with staff, patients and with this committee. And crucially, decisions will always be taken at the most locally appropriate level. Finally, I want to emphasise our commitment to transparency as we shape the group operating model, the clinical strategy, the organisational development programme and the financial framework. We will continue to come and report to you and ensure that HASC has full visibility of progress, risks and benefits. Thank you.
Just very quickly, Dan and committee members, just to add a couple of things from me. I know that one of the questions you may well ask us is, so what's going to be different this time that you've seen other teams previously say, here's the improvement plan for MFT, a few green shoots, and then they disappear and a new team come along. And I think this does link back to the last time I was here, which was with Siobhan, and we went through the cultural transformation program. So I think one of the things that is different this time is that we have a stabilisation plan for MFT, which is the key piece of work over the next year in terms of improving our services, improving our finances, and in particular tackling the culture of the organisation and improving that. So this is alongside that.
Thank you, John, and thank you, Jonathan. Just before I hand over to Member Short Council, one who want to come in, can I just check from, again, no one, just for clarity for members, you're also at the group CEO and group chair process in the new year, right?
So our first step is, given particularly where Medway is to do the group chief exec first. So that's our top priority, to do that. As soon as we can, we'll come back to the chair next year sometime.
So it is a process phased event we're going through over the year. Councillor Waddy.
Thank you. I'm the strong belief that Medway Hospital deserves its own chief exec. I also strongly believe hospitals should work more closely together. That's fine, but I cannot understand why 2 chief execs in 2 neighbouring hospitals, or 3 if you include Maidstone, or any specialist hospital across the world, can't talk to each other, work with each other as they do already. Medway does have its own problems, and I cannot understand why you halve the power of the chief exec by giving them twice as much to do. Now, that's a very simple way of putting it. And also, on the review, I thought 7.1, an independent review to explore the potential benefits. In other words, just look for what we can sell. Don't find out anything that's going to count against this or be to the detriment of. And if you only look for the benefits, that's all you're going to find. It seems, yes, counterproductive to not have one single chief exec, one single chairman, and their own board working under them for each hospital. Thank you.
Yes, I mean, I don't see it the same way. I would say that actually what we're trying to do, and the important thing, is to strengthen the site leadership. So that's not just about who is the chief executive. It's ensuring that our clinical divisions that we have at the hospital are really functioning well in terms of the clinical leadership and the general management, and they're harnessed to the executives who work there. And I think that having a group chief exec, you have the advantage of being more strategic and less operational, but making sure that you have the right team in terms of clinical leadership and operational management to run a 500-bedded hospital. So I think actually that you have the ability, if you do it well, and that's the thing that you will want to test with us over the coming years, that I think it can enhance the leadership overall for the divisional teams that we have and for the executive team.
And regarding the second point, Councillor, I would say inside the Cardinal Farrer report, it's very detailed about the risks as well. I think that they're the potential problems that we might face that you're touching on, all the downsides to it. The next phase for this now is for the successful chief executive, group chief executive, to draw up a more detailed case for change around this, with the exact steps of what's going to happen. And I think we can both say we'd be, I mean, it might not be me, but we can both, John would commit to bringing that back as soon as it's ready, early next year, probably. I think there's a meeting in March that would fit about right with timescales. That will most definitely highlight risks and the mitigations that are being put in place to deal with them.
So I'm going to, Councillor Campbell.
Thank you. There's a theme here tonight, isn't there? Mergers that are not mergers. But okay, I have two questions. I'll be really brief. The first one is what I asked Adam earlier about the medical centre that was planned at Debenhams. So I think because, I mean, it's before your time, Jonathan, but MFT was around the table, ICB was, and the council was. And it wasn't just a paper plan. From my understanding, it was fairly advanced conversations. And we had told the public as councillors that this was going to happen. We were going to use that space in the Pentagon to put a medical centre in there, which aligns with all of the NHS strategy and everything we've heard about today about neighbourhood plan. So what went wrong? And who pulled out? I know Adam talked about financial viability, but then I don't understand why conversations were so advanced before the decision was made to pull out. So that's my first question. The second one I want to say is, you did say, to try and reassure us just now, Jonathan, that there are no immediate plans to move any, change any services. That worries me a little bit. I feel like the whole thing is opening the door somewhere down the future for you to move services out of Medway Hospital. And I think that's the position that Councillor Wildey is concerned about as well, to talk about sort of, you know, strategic partnerships are great, efficiency, all good. But if it comes that, if it transpires that further down the line, you say, well, now we've got this system, we've got this group set up, we don't need two hospitals doing the same service. So we're going to shift this service to Darrenth Valley and things like that, and people are going to have to travel, then that's a problem for us. That's a real concern for us.
Thank you, Councillor Campbell. John?
No, thank you. Picking up the Debenhams point first, I obviously don't know what went on before I started and how advanced the conversations were put across to be. Adam was completely right. It's not, when we've done further reviews on it, when I've looked at it as well, it is not financially viable for the Medway system to do that. I think we are committed to having care closer to home, as you'll see with the CDC's opening in Sheppey and the CDC opening in Sittingbourne as well. And I don't want to close off any possibility that we'll be able to do something in future, but that particular development was never going to be financially viable, and I don't know why it was. It looked like it was going to be at some point. It certainly wasn't when I was looking at it.
Just on the second point about people moving. To say Dartford for services, I think one of the key things will be the roadmap of what changes in terms of clinical, and some of it will be just standardising to make sure we've got the best pathways across both hospitals, learning from each other. But there are some of the services. I was interviewing today for gastroenterology for consultants. Actually, we've offered some posts today. it's a good example of a specialty. Gastroenterology sounds a large specialty. We've got 7 consultants, but it's got lots of subspecialties within it. And the consultants all specialise in one of these areas. And one of the areas is hepatology, which is liver medicine. And one of the questions at the end was, do you think there are any opportunities to the candidates in terms of working together between the 2 trusts? And one of the answers that the candidate says, well, if you look at hepatology, liver medicine, actually MFT has more consultants than Darren Thalley does, and actually we could help them. And they mean help them in terms of work as a group of 4, I think, rather than work 3 and 1, however it is. But that would mean the medical staff moving to do clinics and services. So a lot of this would be actually some of our staff moving to provide a service working together with the others. On occasions, yes, there will be, once we get into the detail, potential for someone to have to, not to have to, but if they wanted their treatment earlier and there was a slot earlier, they would be given the choice of would they like to go to the other hospital and be seen earlier or not. That is a possibility.
And that happens now with certain areas like endoscopy as well. So there is more capacity elsewhere in the county, so people can go elsewhere or they can choose to wait and have it locally.
Thank you, Councillor. Do you want to comment?
Yeah, I'm just really disappointed about the answer about the Debenham Health Centre. I just feel like we've all been led down a merry path and now you're all closing ranks. It doesn't really help us answer our constituents' questions because we did tell them this is what we're doing and it's all, discussions are very positive. But I don't kind of expect that I'll get a better response tonight, so.
I'm more than happy to look into exactly what was discussed at the time and how it came across that way.
I'll pick that up for you.
Yeah.
When it comes back to me, I'll pick it up in a moment. It'll be fine. Thank you, Councillor Cameron. Councillor Perfect.
Thank you, Chair. And firstly, can I thank you both? I think there's a very different style of leadership to some other parts of the NHS that we've seen this evening, actually, and the fact that both Johns are here, Chairman, I think we should acknowledge that, fronting up the Chairman and the Chief Executive willing to front up everything that happens. I think as we've seen elsewhere, sending random deputy directors from different departments to front up decisions that are being taken by people 30 miles away, I think reflects very well on you two, actually, and the leadership that you provide. And I know certainly when we meet regularly ourselves with Councillor Wildy, I know we've got another one in a few weeks, I always find those meetings very positive. So well, thank you both for the leadership that you're showing. Just in terms of this, I mean, obviously, I know we've had some conversations. I think it's good that you commission the external review. I think it needed to be done. I think, John, since you've come on board as Interim Chief Executive, we're already noticing the changes. You've been very clear and upfront, both in the public but also in private, about some of the challenges that are facing the Trust and how best in the interim to achieve those. And I think I very much welcome that because I think it's a change in leadership in terms of the way in which you work with stakeholders, and I think that's very positive, and I think through this report we can see some of that. I do share some of the concerns Councillor Campbell and Councillor Wildy were making about some of the services. But I think, as you've reflected, John Golston, we've got to wait and see where we get to down the line. And I think, I've got confidence that we'll see some of that coming to this committee and there'll be a collaborative way of doing that. I'm just interested in terms of the stability around the Group Chief Executive appointment and the managing directors, if I've understood this correctly, just in terms of how, because obviously without going back through all the history, obviously we've had lots of chief executives, lots of leadership. What I'm just interested in is just probably from you, John, in terms of the process around that, how we're bringing staff on that journey, and particularly your executive leadership team, because I know you've got a number of interim appointments, and just how that sort of piece of work's going to be worked and managed, and then how. I'm assuming you're going to apply, John. I don't know. I wish you good luck with that. How then you'll sort of work from that point onwards, I guess, because I guess the group chair role is also key in terms of bringing the organisations together. And I know you reflected a bit on the timeline, but I'd just be interested in all of that and how that will work and in the briefing. Thank you.
Can I just, before you answer, it'd be good for you to answer. If there's a more in-depth structure it'd be good maybe to send to Terry and then we can send it to members out rather than going through a whole PowerPoint.
So we haven't got to that stage yet. That's the bit that will happen. So the first bit is actually to appoint the chief executive. Clearly, John has ideas, great ideas, but actually you've got to appoint the chief exec first. Then we've got to go through what's the right structure, which we will have for early in the new year. The managing director posts are really important. They will be the site lead. So it's getting that right and being clear on the scope of those roles, how that role will work with the medical lead, the nursing lead, the managerial lead are all going to be vital. And so we need to get that right. We need to think what's the right level for those people to be, who they report to, how that will work, in order to then assure ourselves, in terms of both boards, that that's the right structure that we could then take to the Council of Governors for their view and bring to people like yourselves.
I think the focus for the next 12 to 18 months needs to be on stabilisation of Medway. I'm pleased to say we are seeing areas of improvement. I really hope some of the feedback you get from patients, from staff, hopefully there's starting to be a bit of a shift in some of that narrative, but we've got to continue it. So I will not allow a shift in focus away from that stabilisation at Medway, moving into improved performance and continually developing from there. And that just has to remain the focus of even this piece of work going forwards. So I do think we're going to see the term we've been using is this is going to be an evolution, not a revolution. This is going to be a long journey that I want to take everybody on in this room as well. And I'll always happily come and be honest with you all.
And I think just to add, in terms of from a governance point of view, I'm not keen on jumping to a joint board straight away. That's, for me, another phase. There's so much to do at Medway. We need the right governance and the right board around that. So I think we'll keep both boards separate. My view is to keep both boards separate, certainly in the first phase.
So thank you, Chair. I'm going to be very brief. I think that's really welcome, and I think the approach that's being taken works. I think there's that caution that you've got, John, in terms of keeping stakeholders informed as well, which I think is just really important. So I just stress on that. And I think the stability point is the important thing, not only for stakeholders but for the public and particularly for your staff. I think that's the real key is no more drastic changes in strategy, because I think that's been the challenge that we've had. But thank you very much.
And just thinking I didn't answer your question about the exec team. Yes, there is a lot of interims in those posts at the moment. My intention at the moment would be to either make them very long-term interims, if that makes sense. So as I talk about a 12, 18-month type process, or we decide that that's enough time to actually worthwhile going out and appointing permanently into those posts. But again, that would be a decision for the group chief executive to make at that time.
Thank you, Councillor Beverley. Can I just, I think for me, obviously you was meaning to say, Jonathan, that if you get the post, you'll be back here reminding us.
That was exactly it,
You weren't
Chair.
taking it as
That
read
was
that
exactly
you was becoming
it,
the
Chair,
chief
no.
exec, I presume, yeah. Look, I just want to quickly go back, so the late hour now. I just want to go back on the Debenhams thing for Councillor Campbell. I don't think Councillor Campbell did get a good answer, with all due respect, from the ICB, but it was really at your table, really, because it was MFT that was pushing for that Debenhams site. It wasn't just the ICB or others, it was the MFT. And, you know, it is, I'm not here, I'm going to say it again, I'm not here to blame Jane and her deputy at the time or whatever, but actually, they were the ones that were pushing the council and everybody to get that. And John, it must have been discussed at the board. So I'm not asking for full detail, but I know if you are going to get the background detail, I do want a briefing paper on it, because... Go on, John.
Just a couple of minutes on it. So, I joined the trust in June 24, so I was aware. So, there was in January 25, we were given the opportunity to bid for capital for endoscopy units. And actually, it's an area where at Medway we are short on capacity for endoscopy. So, hence that was proposed. And we put in a business case to NHS England and via the region, and it was given a good, at that point it was supported by the ICB, and the level of capital that was then produced by NHS England was at a much lower level. And our bid was for something like 25, 30 million, but the region only got about 5 or 6 million. So hence we weren't able to progress that. And then actually the capital from NHS England for the sort of schemes has sort of moved on to actually neighbourhood health rather than elective centres. So the ability to get capital from NHS England has reduced markedly. And then we had this potential foundation, if you remember, funding from a foundation, American-based, and the level of return it turned out for that was at a much higher level, and therefore it would have been too expensive. So the problem from our point of view is actually there isn't a capital, there wasn't funding from the NHS to back it up.
I appreciate that, and like I say, if we can get a briefing paper, that'd be great. But I just think, hopefully, that sort of answered your question at last. We got there, because it's not about, but for me, it's not about financial viability necessarily. It's because you didn't get the money. I mean, we know there's gaps, and we know we could have loved that, wouldn't you? You'd have loved a centre like that, but we just didn't get there. But it's a real shame, because there are still some massive gaps. You could do with having. So, we know what the scanner does in Rochester, just at that Dodge surgery, let alone in, having a bigger place. But anyway, just moving on, it is late. You've heard the comments tonight. I think it is about us keeping us in contact, again, about them variations, because all of a sudden you can bet on it, and John knows, from Councillor Wildey especially, if there's any hint, as Councillor Campbell said, of any service disappearing, we'll be on it, because, there's got to be, it's about reasoning why you're doing it and why, because, I'm not going to revisit history, Councillor Wildey. I don't want to open up that wound, but we've had a lot of services taken from us, and maybe, for right reasons, like the stroke service and stuff, but residents are really keen to keep their services, and we have some smashing services in that hospital, neonatal and everything. We have some great stuff. I wouldn't want to see that watered down and moved, but keep us in contact and keep us up to date when you have that final plan, and then we will be hand in hand with you and hopefully give a fantastic service to our residents. That's what we need. That wasn't too bad for you, was it? That was quite nice of me this time. Over to you, Vice Chair.
I move that the committee notes the report.
Agreed? Is that agreed? Seconded, agreed? Agreed. Thank you very much. Thank you for your time. Members, you haven't got just finishing quickly, there isn't no work plan, you'll be glad to know from Terry. I just wanted that be next week. I just wanted to, hopefully we've proven tonight why we needed this extra meeting. Imagine if this would have been at next week's HASC. We'd have been there all night, and we can't do this time. We can't go on for hours. It's just not fair on officers, and it's not fair on us either, or the people coming to talk. But thank you so much for your time, and thank you to subs for coming this evening too. Thank you very much. Good evening. Thank you, Evening.